For the very first session, let me take the opportunity to invite Mr. Jatin K. Sridharan, MSc, FSIQA, and FNIV. Sir has served the renowned Singapore General Hospital in Singapore as senior respiratory therapist. Later, he joined as a specialist in respiratory care at Ministry of Health, Saudi Arabia. He has more than 20 publications in the field of respiratory therapy. Today, Sir will illuminate us regarding oxygen therapy, a practical guide for healthcare professionals. I request Sir to kindly begin with the session.
Good evening to you all once again. Thank you for that very generous introduction, Hemlata. As I said in the beginning, in my opening remarks itself, it's really an honor and privilege for being here with you today. And I'm so thankful and welcome all the delegates once again to this program. We know that one of the things that make a huge difference as far as the COVID-19 concerned, especially our guest of honor and the previous guest, they were highlighting this particular aspect, is around 15% of the patients will be saved just with oxygen therapy. And when hypoxemia with the involvement of lung need to be corrected, every so often with this supportive treatment, an oxygen patient used to get come out. Often oxygen is also given when it is not required actually. You see patients with saturation of 96-95%, and they're asked to start oxygen, which is actually the misuse of oxygen, and that causes unnecessary shortage as far as oxygen is concerned. Today, I will begin this session with oxygen therapy, a practical guide for healthcare providers. Over the next 20 minutes, I'll be talking about very basic practical aspects of how best to give oxygen therapy. What are the routes? What are the mechanisms of hypoxemia or hypoxia in COVID-19? The goals of oxygen therapy and about various oxygen shortage and delivery systems that are available in its care. Especially, I was focusing on to these very basic topics is because we also had a recent experience of sharing or information from many hospitals in our country. They were saying, or not only from the hospital, also from the patient side, they were saying that they gave us oxygen cylinder, but it finishes in just 1 hour. They do not know actually how to titrate it, what flow should be given, how the cylinder capacity need to be calculated, how duration the cylinder is going to hold on. And also we had experience of setting up a mini ICU in one of the rural centers. If you look at our website, the images and the news is also already there. Which we actually find the devices which are available from different locations, and we isolated them and provided it to a rural center where there was no ICU facility around the 100 kilometer of radius. So it was actually a motivational thing for us to start with many training sessions. We conducted all these sessions are free of cost. This is most important. Our platform is actually costing us, but it is all done fully free of cost. There was no charges were involved, and also we provided with the certificates. So let's move on. I have this particular disclosure statement. I have no affiliational, financial, or institutional benefits or conflicts of interest to disclose. Some of the views expressed in this presentations are subjective to the evidence-based practice and anecdotal experiences that are currently available in the literature. All of us know oxygen is necessary for all metabolic processes, and oxygen deficiency impacts organ function. If it is left untreated, it can cause irreversible damage in the due course. The first line treatment of hypoxemia is supplemental oxygen, and hence oxygen therapy is defined as the administration of oxygen at concentrations greater than that in ambient air with the intent of preventing the symptoms and manifestations of hypoxia. Bear in mind that oxygen is a treatment for hypoxemia, not for breathlessness. You must remember that supplemental oxygen is given to improve oxygenation, but it does not treat the underlying grounds of hypoxemia, which must be diagnosed and treated as a matter of urgency. Coronavirus brings widespread inflammatory reaction, subsequently leads to a damage of type 1 and type 2 alveolar cells. This triggers an acute respiratory distress syndrome-like response, resulting in hypoxemia, which could vary in severity. The data from the available study shows that 14% of them will present with type 1 respiratory failure, and out of that, 5% will be requiring ICU admission. This was the data available in the previous time. There's no updated data available at this particular moment. All these levels of mild to severe hypoxemia will require a non-invasive respiratory support. Some patients often do not have breathing problem. There won't be any signs of hypercapnia or signs of hypoxemia or dyspnea, even though they have low saturation. This particular term coins the term happy hypoxemia. And hypoxia in the early phase of COVID-19 causes damage to the pulmonary vessels and impaired transfer of oxygen. However, if the patient deteriorates, his lungs will worsen to ARDS. I'm explaining all the terms in a very simple language for multidisciplinary attendees and delegates to understand. So, development of this interstitial pneumonia causing mild to moderate and severe hypoxemic respiratory failure then leads to ARDS, shock, and multi-organ dysfunction syndrome. As you're aware, COVID-19 infected patients are categorized into mild, moderate, and severe categories. In patients with moderate to severe disease levels, oxygen therapy is a necessary initial treatment. Remember, oxygen therapy needs to be performed in rational with close monitoring without delaying intubation. There are simple ways to determine whether the patient needs oxygen therapy. The first is the use of laboratory measures such as arterial blood gas testing to document hypoxemia. Now, most of us are very familiar with pulse oximetry. If it says oxygen levels less than 94%, which is a requirement for oxygen after completing the medical evaluation. Let me say oxygen saturation should be checked by pulse oximetry in all breathless and acutely ill patients, which is now and before also it was considered as the fifth vital sign. And it is very important to document the inspired oxygen concentration at the time of measurement on the observation of respiratory therapy chart or nursing charts. With the oximetry result, it is important to know the low or high saturation was noted while the patient was on oxygen supplementation or on room air. Secondly, the patient need for oxygen therapy can be based on the specific clinical problems or conditions. That's the traditional way. Uh, Finally, the physical signs. Hypoxemia may cause tachypnea, tachycardia, cyanosis, and distressed overall appearance. Perhaps it is important to understand, especially in COVID-19, we are dealing with illness that are rapidly evolving and the patient can rapidly deteriorate. Therefore, we should not give oxygen at limited facilities and feel complacent that we have given the appropriate treatment. So if a person's oxygen level is dropping at home or a primary care center, the complete care that he requires can be given only at a hospital facility. Refer the patient early to the center where you have a high level of care and facilities are available. The main objective of oxygen therapy is to keep an acceptable tissue oxygenation. By supplementing the oxygen, we will be increasing the alveolar and blood level oxygen to correct hypoxemia. In addition to that, it decreases the symptoms which are associated with hypoxemia, such as dyspnea and altered sensorium. Oxygen therapy also decreases the cardiac workload and reduces the pulmonary vasoconstriction. The saturation target can be aimed at someone if they are admitted in a ward from 90 to 94%. The idea is to decrease the wastage of oxygen and associated complications of hypoxia. In the ICU where your patient is in a highly monitored setting, target even a lower saturation that is can accept up to 90% or 90 to 92%. Importantly, look at the oxygen dissociation curve. How does it flatten? And what are the actual saturation you need in a given patient rather than wasting oxygen? You know that after you reach the oxygen saturation of 90 plus, the dissociation curve is almost getting flat. Therefore, After that, no need for pushing the patient or the monitor to show you a 99 to 100%. Actually, you will be wasting of oxygen. A sigmoid curve that we have in oxygen dissociation, we don't want to be in the steep part of the curve. Therefore, I recommend you to individualize your treatment plan with every patient. Let's look at the sources of oxygen. We are hearing about oxygen concentrator in a great extent. An oxygen concentrator is simply an electrically powered device intended to distillate oxygen from atmospheric air. I was aware that government of India recently declared they will be securing 1 lakh plus oxygen concentrators and distribute them to the high burden states as an alternative to the depleting resources of liquid medical oxygen. A scarcity of oxygen cylinders definitely have pushed these concentrated market at the forefront of home isolated patient. It was available in our market very long time before, and this moderate patients in the hospitals, but using the correct specification, all those things are very important. You must know that what is the production capacity of each oxygen concentrator that you purchase. Just looking at the price itself is not sufficient when you are purchasing an oxygen concentrator. There are mainly two types of oxygen devices. I mean, oxygen concentrators are available. If you categorize them into portability, it is portable and home for home use, for fixed home use. If you consider this as low flow and high flow, there are two types of devices available, which some oxygen concentrator will give a flow up to 5 liter only, whereas the other high flow oxygen concentrator will go up to 10 liter. So this category, this depends on this particular category. The prices of the oxygen concentrator also will vary. So this information is very important for the patients who are taking care of themselves at home, or they are purchasing this machine, and some tertiary, or I mean primary care centers, or rural care areas where they are thinking of purchasing the oxygen concentrator instead of setting up a full oxygen plant, because their turnover may not be that high. So there are these transporting or portable oxygen concentrators can be taken on your shoulder, and they can go for a morning walk on every day. But the thing is, it will not be producing more than a flow rate of 2 liter, or this concentration of this oxygen produced from this device is 90 to 95%, but the flow rate will be always low. That is the difference between the portable and the fixed or the non-portable devices. The care must be taken while using an oxygen concentrator. The machine should be always kept at least 2 feet away from the objects or wall where you are keeping the machine. The filter should be checked periodically for blockage and debris based on the manufacturer's recommendations. The most important thing that you must remember as a healthcare provider, concentrator is not a device for emergency use. It will take minimum 20 minutes to produce high oxygen concentration of oxygen once you turn on the device. So it will not provide you high concentration of oxygen, same as that of a flow meter that you're using in your hospital or at the bedside. You're very familiar with oxygen cylinders. However, I will share some practical aspects pertinent to the cylinder usage. The first image is a liquid oxygen cylinder, which is not commonly available in our country. Because why I'm showing you, because it is not available because it's very costly and not very easy to refill and maintain. However, nowadays we are receiving enormous support from the friendly nations. They are sending countless oxygen supply systems to overcome the crisis that we faced recently. So you may find one at your hospital. The advantage is 1 liter of liquid oxygen will produce 860 liter of gaseous oxygen. It is lightweight, it is portable, and can deliver oxygen at all flow rates that is starting from 1 to 15 liter, as same as that of a regular oxygen cylinder. Second one, the picture as you see is the hospital ward outlets that are very familiar and familiar for you. There are 50 PSIG pressure is maintained at the outlet. No need to monitor the storage capacity and all, because it will be taken care by the biomedical department or the oxygen officer. Compressed contain a cylinder that you can see at the last, which contains oxygen in the gaseous form. It requires a pressure reducing valve and a flow meter to deliver the desired flow of oxygen. There are multiple size cylinders are available in the market. The three sizes of oxygen cylinders commonly we used to have a capacity of 660 liter, that is E cylinder type, and then F cylinder and H cylinder, which is the highest, 6,900 liter per minute, liter of total capacity. The duration of flow of a cylinder can be estimated. That's what you must know. If you know the gas flow, the cylinder size, usually big cylinders and H cylinders, or a small cylinders size E. We'll take only these two cylinders because they are the most commonly seen cylinders. Based on the cylinder size, and you can choose a cylinder factor, which is constant for these cylinder sizes, and the cylinder pressures at the start of the therapy can be monitored on the pressure gauge fitted on the cylinder top. So remember this formula: cylinder pressure in PSIT multiplied by cylinder factor divided by flow in liter per minute. All these devices that I showed now is going to deliver 100% oxygen. If you look at this particular example that I am showing here, there is a reason why I specifically mentioned this scenario, because it is reported from many hospitals recently that a person prescribing usually the oxygen, they will go after some time and they will be setting a 2 liter of flow. Some a ward boy or a relative who is taking care of the patient will be just increasing the flow of the cylinder or the oxygen flow from 2 liter to 6 liter or 4 liter. So if you double the flow, it will have the life of the cylinder that's harmful and bring fatal results. Replace the cylinder always when the cylinder pressure goes below 200 psi. That is also another thing that you need to care for. So you can calculate the values by putting this formula. If you have, it's very easy calculation. You have different other calculations also available by utilizing different formulas, but this is the easiest one for you to understand, that if you remember the cylinder factor, and that is also very easy. If it is E cylinder, it is 2.18, and if it is an H cylinder, it is 3.14. These are the only two values that you need to remember as a constant value. When you care about the cylinders, storage is very important. Store the cylinders away from any combustible material and away from boilers, open flame, steam pipes, or any potential sources of heat. That is important. If a cylinder is not in use, keep the protective cylinder cap in place, contain the cylinder and supply systems in an enclosure that is well ventilated. Do not store air compressors and gas cylinders together. A fire involving one or other than can damage both gas delivery systems. Segregate a full and empty cylinders. Always store them separately possible. Place on each one on a floor or a gate of enclosure with a sign indication the presence of an oxidizing gas, suggesting caution in patient, particular against smoking. And such signs must be readable from a distance of at least 5 feet away. So further to that, store the gas cylinders in racks or chains with cylinders to the wall to prevent them from falling or becoming damaged. Use cylinder cards with the securing mechanism for transportation of cylinders always. When gas source is a high pressure gas cylinder, a regulator or a reducing valve plus a flow meter is required. In order to deliver appropriate amount of oxygen, the pressure of the gas need to be reduced so that it can be safely given to the patient. Flow meters are devices that help to deliver a fixed flow of oxygen to the patient. Mainly two categories of flow meters are used in the respiratory care. If I say that is one type is Borden gauge and the other one is top tube. The top tube has two different designs. One is pressure compensated, another one is uncompensated. You can easily identify when you connect a pressure compensated one, the ball will immediately jumps up. So these two types, mainly Borden gauge and the top tube, need to be identified because the Borden gauge is not a gravity dependent one. it is not affected by gravity. So particularly when you think about transporting a patient from one place to another, intra-hospital or inter-hospital transport, you may have to keep the cylinder under the bed, or sometimes you will not be having a hanger. What will happen is you will keep the cylinder lying flat on the bed. It will cause, the tube, the flow meter is getting affected because of the gravity. And always remember to keep the cylinder in upright position, yes, if your cylinder is connected with the regular torque tube flow meter. Look at the type of devices, low flow and high flow device. I'm going to simply explain it with this particular picture. The general performance characteristics of oxygen systems has paramount importance in the successful oxygen therapy program. In a low flow system such as nasal cannula, simple face mask, non-rebreathing mask, the patient needs to draw the remainder air from his minute volume requirement from the surrounding air. Therefore, more the minute volume, lower the FiO2 is being delivered. Whereas a high flow delivery system provides a full amount of air that the patient inhales. Therefore, the FiO2 remains stable. This simple diagram explains what I was telling you earlier. The blue dotted line in the is the flow of the device. In a low flow device, as you can see, as long as the minute volume remains less than the patient device's total gas flow, and FiO2 remains stable. However, if it is increasing, it will no longer deliver the high FiO2. On the other side, the high flow device is already providing adequate gas flow. As you can see, that is marked as B in the figure, to cater for all kind of needs. These are the differences between high flow and low flow devices. A holistic assessment of the severity of the patient's respiratory condition is essential to start and escalate the oxygen therapy. For patients with moderate to severe dyspnea with a respiratory frequency of 20 to 30 breath per minute, saturation of less than 94% in room air, and a PO to FiO2 ratio of less than 300, oxygen can be initially given through a nasal cannula, then titrated to a simple mask and to a venturi mask up to 60% if it is needed. Then titrate to a non-rebreathing mask up to 15 liters per minute, and finally you can think about moving to high flow nasal cannula and non-invasive ventilation, and further to intubation and ventilation. Via a simple nasal cannula, the oxygen flow rate at typically 1 to 6 liters per minute, which delivers an FiO2 of 24 to 44%. Perhaps you can spot in the table every 1 liter increase in oxygen flow, above 4 liters per minute, consider using a 4% of FiO2 is observed. Nevertheless, do not exceed 6 liters of flow, because such higher flow rates will irritate the nasal mucosa. Even that can lead to bleeding. If you are using a flow rate above 4 liters per minute, consider using a humidifier always. Whereas a simple face mask has exhalation pod on the sides that allows the room air to be drawn in and mix the oxygen supplied. At a flow rate of 6 to 10 liters per minute, a simple face mask can deliver an FiO2 of 40 to 60%. Remember, do not deliver a flow rate below 5 liters per minute on a simple face mask. This will lead to carbon dioxide rebreathing, and that will give you a negative result. Now, a non-rebreathing mask that combines with a reservoir bag, which can be filled with oxygen, and then the patient inhales and he draws the pure oxygen from the reservoir bag itself. When the exhaled air escapes, or when the patient is exhaling, the air is going to escape through the side port, not back to the reservoir bag. Another approach is specifically gained attention during the COVID-19 time is to place a non-rebreathing mask over a nasal cannula. Certainly, this is good, which delivers an effective FiO2 by preventing the inadvertent accumulation of carbon dioxide in the hypo or nasopharynx. Ensure that the reservoir bag is always filled with oxygen. 12 to 15 liters of oxygen flow is required. I'm going to show a video. In this particular video, you can see the bag should be at least 1/3 even during the inhalation. However, all these modalities can also be given as the first line oxygen therapy depending on the patient condition. Now, thinking of escalating the oxygen therapy. When considering a stepwise approach to providing supplemental oxygen, start with either a nasal cannula or a simple face mask. If the patient fails to improve this with these devices, then apply a non-rebreather or a non-rebreather over a nasal cannula and go on. We have great concern over the management of pediatric patients, and we clinicians often find it difficult to manage them due to poor tolerance. There are many pediatric delivery devices available with funny, attractive designs, so, though their efficacy is always a matter of concern. There are no specific guidelines states on what should be the minimum flow or maximum flow with respect to the variation in their sizes. The World Health Organization recommends oxygen therapy if the saturation is less than 90% for children with signs of respiratory distress. The American Heart Association 2020 PALS guidelines state oxygen should be administered and weaned to achieve between 94 and 99%. Interestingly, this particular systematic review published in the Respiratory Care Journal just 2 days ago um, uh, does not recommend using an oxygen hood or a tent instead of low flow oxygen device for consistent oxygen delivery. They recommend HFNC as a safe and more effective than conventional oxygen delivery devices. It is a very important recommendation to consider in the pediatric patients with unstable hypoxemia. And I'm glad that one of the author who published this article agreed to join with us in this particular day. This article was published in the Respiratory Care Journal, which is the official publication of the American Association of Respiratory Care, and all these authors are respiratory therapists. They also not recommend, in hospitalized pediatric patients suffering from respiratory diseases, establishing a patient disease oxygen therapy target upon admission is identified more effective, but a specific target is not particularly recommended in this particular uh, systematic review. The evaluation of therapeutic response should be done at least uh, every 30 minutes in the first hour and then every hour. If the conventional oxygen does not provide uh, clinical improvement, you can consider high flow nasal cannula. It is very important to closely monitor the patients in the first, second 2 hours. Monitor pulse oximetry, arterial blood gases, work of breathing, maintain power levels of supplies, especially when using an oxygen cylinder at remote locations or while transporting the patient. Readjust the interface routinely to avoid pressure source. Do not over tight the interfaces or the head straps. Check for mucosal dryness. Cloxidine mouthwash can be given every 6 hourly. Taking into account the possibility of silent hypoxemia, especially in older patients. If there is no clinical improvement, consider non-invasive or invasive mechanical ventilation. And you may follow this particular algorithm by LC published in this SMJ in the last December. Uh, Avoid benzodiazepines or narcotics in the initial treatment of agitated patients. Giving these drugs for a patient who has agitation due to hypoxia could be lethal. In patients with COPD, emphysema, be careful when administering oxygen. These patients often have hypercarbia, so the over administration of oxygen for an extended period of time can affect their hypoxemic respiratory drive, which will lead to further hypercarbia, altered mental status, and even a complete respiratory collapse. Check the oxygen is flowing always, tubing are connected always, and they are not kinked. The cylinders are adequate, having adequate storage, etc. The literature says that all forms of oxygen supplementation may potentially aerosolize the respiratory pathogens such as COVID-19. Take necessary measures to protect ourselves and our patients. A well-fitting standard surgical mask can significantly reduce aerosolization when placed over the oxygen therapy devices. Therefore, consider to place a surgical mask over the oxygen delivery device, as you see in this particular image. I would like to conclude by sharing this particular article published in the May-August issue of Indian Journal of Respiratory Care. Obviously, supplemental oxygen therapy is a life-saving supportive therapy in hypoxemic COVID-19 patients. A rational management of oxygen therapy includes the provision of initial therapy followed by proper monitoring and escalation without delaying intubation. And supreme consideration must be given for the healthcare workers' protection and the risk of transmission. Thank you so much for your patient listening. I'm open to reply to your questions if you have any. Please post it in the chat box. Thank you so much.
Thank you so much, sir, for illuminating us regarding the extensive practical guides regarding oxygen therapy. Once again, I request all the attendees to drop the queries related to any of the lecture in the chat box or a Q&A session. There is a section at the down that is a Q&A. You can send your queries over there also. For our next session, I am pleased to invite Ms. Momita Chakrabarti, lecturer and clinical coordinator from Narayana Institute of Allied Health Sciences, Bangalore. Madam has completed her master's in respiratory therapy from Symbiosis International University and has more than 6 years of clinical and teaching experience. She is also the author of more than various publications in the specialty. Today, Madam will update us regarding high flow oxygen therapy in COVID-19. I request Madam to begin with the presentation. Over to you, ma'am.
Excuse me, Momita. Momita, your mic is muted. I'm sorry. Thank you.
Please kindly allow me to share the screen. Thank you. So good evening to all the dignitaries, delegates, and all the participants. I'm very much honored to have this platform today. Today, the topic of discussion that I would be conducting is on the high flow nasal oxygen in COVID-19. So I have a disclosure to make. I have no affiliation, financial or institutional benefits or conflicts of interest to disclose. Various equipment which has displayed here in my presentation are solely for the academic purpose. Some of the views expressed in this presentation are subjective to the evidence-based practices and anecdotal experiences that are currently available in the literature. So first we would know what is high flow nasal cannula. So high flow nasal cannula, also as we call it as HFNC, is an oxygen supply system which is capable of delivering up to 100% humidified and heated oxygen at a flow rate of up to 60 liters per minute. It is not the same as the standard nasal cannula which we use in the hospital setting, because the standard nasal cannula is a low flow variable device, while high flow devices are fixed and they can provide high flows up to 60 liters per minute. So in COVID-19 often progresses to acute hypoxemic respiratory failure that requires higher oxygen concentration to maintain the FiO2. So that might not be achieved with the help of conventional oxygen therapy devices, such as simple mask or a non-rebreathable mask. That is the time when we should consider the use of HFNC. So now we would go through what are the physiological benefits of high flow oxygen therapy. First, it is more reliable delivery of FiO2. Since it is a fixed oxygen delivery system, we can ensure that the FiO2 which we have set for the patient is achieved by the patient. And it does not depend on the patient's inspiratory flow. Another most important physiological benefit is the anatomical dead space washout. So we know anatomical dead space is the amount of air which remains in the conductive airways and which does not take part in the gaseous exchange. So when we apply high flow to a patient, because of the high flows which are delivered, it will basically wash out the exhaled air from the upper airway, and due to which there would be reduction in rebreathing. That will also impact the work of breathing by making it less and improve the ventilation. Also, there would be an improved mucociliary clearance. Since the high flow which we are giving to the patient, there is a heated and humidification guaranteed. That's the reason why there would be an improved in the mucociliary escalation. And we also have a PEEP effect. So with the application of high flow nasal cannula, with every 10 liters per minute of flow that we set on the high flow, there is 1 centimeter H2O of PEEP that has been generated. So somehow it will help in the alveolar recruitment. So these are the mechanisms. So H stands for heat and humidification. So 31 to 37 degree of temperature, which is equivalent to our body temperature, can be achieved using the high flow. Along with that, 100% of relative humidification can be achieved. Now this would improve the mucociliary clearance, avoid the epithelial injury, and definitely it will enhance the patient comfort. For eye, we have Inspiratory Flow, which would be up to 60 liters per minute, and that would help the patient in the breathing. Also, it will reduce the inspiratory demand. Then it will also restore the functional residual capacity because there is a generation of PEEP in the circuit while we use HFNC. It is lighter because we are using very soft nasal prongs, which enhances the patient comfort, and the patient can eat and drink anytime. Oxygen delivery, since it is the fixed oxygen delivery system, we can ensure that the FiO2 which we have set is achieved by the patient, regardless of his inspiratory efforts. And definitely the washout of dead space, which I have already explained, which improves the ventilation and the oxygen delivery. So what are the indications to HFNC? First would be the acute hypoxemic respiratory failure. There are several recommendations who have stated that HFNC is one of the modalities to be used at acute hypoxemic respiratory failure. I will be talking about it in my upcoming slides. When the SaO2 is less than 92% despite supplemental oxygen given via the conventional oxygen delivery devices, as I mentioned, like simple face mask, NRBM, etc., where we can also initiate HFNC in the pre and post extubational oxygenation, and when there is a status of do not intubate for the patient. However, HFNC is not a magic fix. So if there are any signs of clinical deterioration where intubation is required, we will not delay the intubation. HFNC is definitely not an alternative to intubation. And there are several contraindications to HFNC, which is very important to note before we start or initiate or even consider the HFNC for a patient. First, hemodynamically unstable patient who requires a high vasopressor support, unstable arrhythmia, where there is severe respiratory acidosis and the pH is less than 7.2, altered mental status, epistaxis, recurrent apnea or respiratory arrest, known nasal obstruction, basilar skull fracture, or even multi-organ dysfunction. Now coming to the equipment, again, we are not endorsing any of the product here. This is just for academic purpose. So there are various such devices which are available in the market. And the high flow is basically a compact device which is integrated in a mobile pole. So it becomes very easy for us to use it in the bedside since it is not bulky. So these are some of the types which is there in different hospitals, and as per protocol, it is used. So what are the components? So these components are common to all types of devices. First, there would be a flow generator, which will be providing the gas flow rate up to 60 liters per minute. An air and oxygen blender that is basically concerned with escalation of the FiO2 from 21% to 100%. A humidifier that saturates the gas mixture at a temperature of 31 to 37 degrees. And to minimize the condensation, we are delivering the gas through the heated tubings and using a nasal cannula or any other patient interface. So this is the HFNC instrumentation. Again, the first picture denotes the heated plate. This heated plate is responsible for maintaining the temperature that we are setting for the patient. The second picture shows the chamber, that is the water chamber, that is concerned with the humidification. So in this device, it is a passive humidifier. Then the third picture shows the oxygen port, and the fourth is the patient interface. So this is a very simple depiction of HFNC, and different models would be little different from each other, but the basic functioning would be the same. And there are various HFNC patient interfaces, like we have the adult nasal cannula, even junior nasal interfaces, and tracheostomy interfaces. So how do I set up the equipment? First, make sure that the equipment is disinfected. So as we on the machine, you will get a symbol, or let's check where we can check whether it is disinfected or not. The green indicates that we are ready to initiate it to the patient. Then we would connect a 1 liter of sterile water bag that is used for the irrigation. We will fill the water chamber up to the marked level and then connect the tubings. That is the inspiratory tubing and with the nasal cannula, both the patient side and the machine side. Now, initiation of the HFNC. So first and foremost step is to find out which nasal cannula to be used for which patient. Adult nasal cannula can give up to 60 liters per minute of flow. So this is the picture of an adult nasal cannula. Second is we would select the mode, whether it is pediatric or whether it is adult. Then we would set up the temperature. So usually the temperature is between 31 to 37 degrees, ideally to be kept, but this is totally dependent on the patient's comfort. Then we would also set up the flow. So flow initially we would set from 30 liters and it will ramp up to 60 liters per minute. Now this involves the patient comfort. And we would set the FiO2. So these are the various recommendations from various bodies like WHO, NIH, SCICM, and ANZICS, who have actually mentioned and about the HFNC to be used in different cases such as mild ARDS and in acute hypoxemic respiratory failure. This is a summary of all the guidelines that we have got from the Society of Critical Care Medicine, Surviving Sepsis Campaign, and ESIC. So if there is a patient of COVID-19 with hypoxia, first thing we check is whether there is any indication for endotracheal intubation. If there is an indication, we would not delay it due to any reason, we would go for the endotracheal intubation. If not, if there is no indication, we would see whether the patient can tolerate supplemental oxygen given by the conventional oxygen delivery devices. So here also, we would check whether the patient can maintain our targeted SpO2, that is around 92 to 96%. But if the patient is not able to maintain it, that is the time when we will consider the HFNC. And there also, we would target the saturation from 92 to 96%. It may happen that you have initiated the HFNC and the patient has developed signs where endotracheal intubation is required. Again, we would not delay. We would put the patient for, we would go for an endotracheal intubation. So the gist of this slide is, even if I'm considering the HFNC, it does not say it is an alternative to endotracheal intubation. So initiation. So initiation of HFNC in COVID-19 can be done at an early stage or late stage. So what is an early stage? So early stage is when the PF ratio is less than 300 or the SpO2 is less than 93% with an oxygen of 5 liters per minute, or SpO2 is less than 94% with an FiO2 of 40%. Now this is the criteria for an early start. The late start is when the SpO2 has dropped below 92% and the oxygen which we are giving is already at 15 liters per minute with a PF ratio less than 150. In both the cases, the start would be the same. So first we would ramp up from 30 liters per minute until the 60 liters per minute of flow. FiO2 of 100 to maintain a saturation of 92 to 93. That can be again titrated with the consequent ABGs that we will be doing. And the temperature would be set based on the patient's comfort. That is from 31 to 37 degrees centigrade. Patient monitoring in HFNC. So when we monitor the patient, the first thing that we monitor would be based on the clinical judgment. Like, what are the clinical determinants? First, yes, symptomatic improvement, whether it is there. Whether there is improvement in the tachypnea. Whether the patient is maintaining the oxygen saturation, and whether there is satisfactory ABG, that is the pH, the PaCO2, the PaO2. And also when there is a feeding tolerance. So these all are the clinical determinants. Along with that, there is an index called as the ROX index. So this index was given to us by Roca in his paper, an index combining the respiratory rate and oxygenation to predict the outcome of nasal high flow therapy. So what is this ROX index? So this is the ratio of oxygen saturation over FiO2 over the respiratory rate, a score to predict the outcome of HFNC. And it is performed at the 2nd hour, the 6th hour, and the 12th hour after the initiation of HFNC. So they have found a value that is greater than 4.88 measured at the 12th hour, indicates that the patient is maintaining well with HFNC, and we can continue the same. So when we are measuring the ROX score at the 2nd, 6th, and the 12th hour, we have to check for the following parameters. So at the 2nd hour, if the ROX score is less than 2.85, at the 6th hour, less than 3.47, and on the 12th hour, less than 3.85, all will indicate HFNC failure. So for example, there's a patient who has a saturation of 88% at the 6th hour, respiratory rate of 28 breaths per minute, and at FiO2 of 0.7. So in this, I can calculate the ROS index, which comes to 4.48, which is a greater value than 3.7. So this would indicate that we can continue the patient on HFNC. Also, HFNC can be combined with other techniques like prone positioning. So we all know that prone positioning is one of the modalities which improves the ventilation perfusion coupling. And combination of both would help us in achieving better oxygenation status for the patient. But we would require research studies with a large number of samples to validate the efficacy of combination therapies. Right now, I'll again speak about the weaning, which is very important because at each step, we need to have a proper monitoring of both the clinical factors and the indexes. Like first would be the drop down of the FiO2. We would first consider to decrease the FiO2, and we would have a target of about 92%. Once the FiO2 reaches around 50% and the patient can maintain the SpO2 above 92%, then we will titrate the flow rate. Again, we will not decrease the flow rate at once. It will be around 5 to 10 liters per minute every 4 hours in case of an adult patient. Then we would check whether there are signs of respiratory distress, or do we have any kind of distress or where we have to again escalate the therapy, whether the ABG is satisfactory. If we find yes, the ABG is satisfactory, there are no signs of respiratory distress, clinical improvement is there, that is the time when we would decide on switching from HFNC to a conventional flow mask, maybe a simple face mask. Now, one of the concerns in this COVID era was the aerosol generation due to various procedures because they pose a severe threat to the healthcare profession. So in one of the papers by Jessica Whittle, she has mentioned regarding the aerosol dispersion distances, which is concerned with HFNO, then NIV, nebulizer simple face mask, venturi mask, and nasal cannula. So here we can see that with HFNO, the aerosol dispersal distance is around 7 to 10 centimeter, which is much, much lesser as compared to NIV or nebulizer simple face mask, and even the nasal cannula, which is the conventional. However, to make sure that the aerosol generation is least, it is very important and it is a must that personal protective equipment should be used by the healthcare professional every time they go to attend to the patient. And we can consider the negative pressure rooms. Also, we can use a surgical mask over the nasal prong of the patient. So basically the goal is we would try to minimize the spread of the aerosols or aerosol dispersion that might pose a severe threat to the health of the healthcare professional. So with this, I end my presentation. I'm really honored and grateful that I've got this opportunity. I'm open to any questions. Thank you so much for your patience listening. Thank you.
Thank you so much, madam, for updating us regarding use of high flow oxygen therapy in COVID-19. I think various queries of the participants will be like FIO2, how much to be maintained. These things you can put it into Q&A, and madam or either other dignitaries will be or panelists will be sending you the answers. So I request again to put the queries in the chat box or a Q&A session. Moving ahead, for the next session, we are glad to invite Dr. Devendra Kumar Tripathi, Additional Professor, Department of Anesthesiology, Vice Dean, Innovation, AIIMS, Rishikesh. Sir has completed his DNP from National Board of Examination, Delhi. Sir has rich experience of more than 15 years of PG teaching. Sir has various publications to his credit. He is the winner of Grand Challenge Exploration Round 5 by GCI to develop intubating video stimulate. Today, Sir will appraise us about NIV, non-invasive ventilation in COVID-19. I request Sir to kindly begin with the session. Dr. Devendra Kumar Tripathi.
Thank you, madam, for the kind words. I can share my... Am I audible and screen is visible?
Yes, sir.
I am really thankful to the IARC, Professor Sindhwani and Dr. Lokesh for giving me this opportunity and to be part of this teaching and learning experience. So the topic, I'll straightforward, I'll come to the topic. The topic which is given to me is a non-invasive ventilation in COVID-19. And this is a most commonly used nowadays, but a lot of queries are there. So before moving on to the topic, I have a few disclaimers to make, same as the other two speakers. Whatever I'm presenting is this particular COVID scenario. Every day, some new evidences are coming, new knowledge is coming to the community. So I'm presenting whatever available evidence and opinion I could gather. And few of the images are used from internet. It is purely for the educational purpose. And I have no conflict of interest. Coming to the objective of my session, I have been given 25 minutes by Dr. Lokesh. So what he has asked me to do, I'll try to do it in 20 minutes. So I'll be just focusing on the basics of non-invasive ventilation and the use in COVID scenario. And what I won't be doing is the detailed settings and each parameter settings I will not be focusing. And in-depth literature review also I will not be doing, but I will be happy to take any queries in any of these areas if the participants wants. So coming to the first thing first, what is non-invasive ventilation? In the simple word, a ventilation or a mechanical ventilation without an invasive airway. So invasive airway means either endotracheal tube or a tracheostomy tube. If I want to be very specific and technical in my definition, so I would like to call it as a non-invasive mechanical ventilation, and the context which we are talking is a positive pressure ventilation. There are methods to do negative pressure ventilation too, which it is out of our purview, so we are not discussing. So to be very technically specific, we can call it as a non-invasive mechanical ventilation positive pressure. So like you can call. But if you remember, we are almost 1.5 years into the pandemic. And initially when the pandemic came, the non-invasive ventilation was a relative contraindication in COVID patient, mostly due to the fear of aerosolization. Yes, it caused a lot of aerosolization. But then once the pandemic progressed and people got more evidence and all these things were settled, and then people used more and more. And now we have come to a situation where it is a very commonly employed strategy in COVID-19. Some authors and some publications are questioning, are we overusing it? Are we misusing it? So it has come a total 180 degree from the beginning of the pandemic to now, the current scenario. So what we need to do is we have to use this strategy particularly in right patient using a right equipment and use a right strategy. That is the key. No, it is that is what we have to focus. Just briefly, there are COVID ARDS pathology, pathophysiology is a huge topic, and nobody is 100% clear about what is happening. A lot of things are there. I'm not touching everything, but just I want to touch 2 points. So that is relevant in non-invasive ventilation. Earlier part of the disease, the lung is compliance is good. They are like they do not require a lot of pressure to inflate their lung. And that is sometime being categorized into L type and H type lung. Again, that is being questioned. But what we remember is the first part of the disease or the initial mild to moderate disease, the compliance is good. So ventilation is actually easy. Non-invasive ventilation would be easy. Second thing is there is a vasogenic component to the pathology. That means the hypoxic pulmonary vasoconstriction, which happens in the normal lung, is impaired in COVID patients. And there is a disrupted vasoregulation. So that leads to a lot of vasodilatation. So if you overinflate a lung by means of non-invasive ventilation or invasive ventilation, that can cause a lot of dead space, physiologic dead space. So coming back to the pathology, if I want to term simply that initial part, what is it? It is an acute hypoxic respiratory failure that progressed to type 2 failure later part of the disease. But most commonly, 95% of the time, as the first speaker also pointed out, it is acute hypoxic respiratory failure. And how do we support this acute hypoxic respiratory failure? By 2 methods. We have to maintain the oxygenation. At the same time, we have to look at the work of breathing. Which is not much. We have to keep the work of breathing in the normal range. Now, to achieve this too, and understanding the pathology, the ventilatory strategy was being debated many times. Thousands of literature has come. Many great minds have put their insight into the thing. Like we have as I have mentioned earlier, L type, H type, then happy hypoxemia. Then there was a huge discussion in the academia that early intubation versus late intubation, what should be done. A group of authorities said that early intubation is the key. Then the group of authorities said no, we should delay the intubation as far as possible. Even the non-invasive ventilation, when it came to picture, you can see a title like non-invasive ventilation for acute respiratory failure, the non-ending study. So a lot of things has been discussed on that. So just to give a perspective on that. So if you go back and see what was happening, what was the role of non-invasive ventilation in ARDS, pre-COVID era. This is from a standard textbook where you look at the role of non-invasive ventilation was limited to mild ARDS situation. Initially, it was even that situation people were not hesitant to use. Then more and more evidences came. So they were using and that PF ratio of 200 to 300 and the mild disease. But in this pandemic, what has happened is people have in the desperate situation when the non-invasive modalities are not available, patient is not willing to give consent because everybody thinks that intubation means death warrant to the patient. So people have refused to give consent. So it is also being used in severe ARDS. This was not done previously because we know that the recruitment is so important in ARDS, and 100% sealing and continuous non-invasive ventilation is not possible. So recruitment and de-recruitment cycle actually harmful, but it is being done in many patients because of the 2 reasons. One, the patient, they do not give consent for intubation, and there are some limitation in the equipments too. Now coming back to the technique, as I said, I'll be covering the basics. So this can be done in the device which can deliver the non-invasive ventilation are categorized into 2 types. One is the portable non-invasive ventilators, or commonly known as BiPAP. Means they are single limb circuits. They use one only delivery of air, and the air goes out to the atmosphere. And you can use ICU ventilator, not all ICU ventilator. Of course, the current ICU ventilators come with NIV modes. The ICU ventilators which has NIV mode. So that is the another category of equipments you can use. Again, in each category, if you see, the devices come in various sizes and shapes. and various modes and capability. You can see that somewhere you will not have any screen, you have bigger screen for setting and some patient input you can get, and the conventional ICU ventilator with NIV modes are more capable. So in this context, I would like to point
I think there is some issue with DKD Patisar's network connection. We will, take care of it. Just be with us. He'll join soon.
Okay, till the time we resolve the technical issue, I'll talk about the IARC. Indian Association of Respiratory Care, IARC, is the sole professional association of respiratory therapy professionals and students of India ever since it was established in 2006. The academic wing of IARC, the Indian Academy of Respiratory Care, was instituted within the governance of society, aiming at the enhancement of academic, clinical, and research activities of its members. As a part
Ms. Hemlata, DKD Patisar is here. Sir, start this. Sir, you are muted right now. Please unmute. Sir, please unmute yourself.
Sorry for the disruption because of the internet connection I lost. So can you just point out where I was? I think I was in this slide. Can I continue? Hello?
Share the slides.
Please share the slides, sir.
Yeah, I'll just go. Is it visible now?
Yes, sir.
I was in this slide, I believe.
Yes, sir. Yes, sir. This slide only.
Okay. So as I mentioned that the conventional ICU ventilators are more capable, particularly in the COVID-19 scenario. And then the most important component of non-invasive ventilation is the interface. These are the classic 6 interface: then oronasal mask, hood, total face mask, nasal pillow, mouthpiece, and nasal mask. There are more different type of hybrid masks are coming. Even the 3D printed customized masks are also there. These are very important because the 50% or more than 50% are failure of this non-invasive ventilation is because of improper interface. It comes in various sizes and shapes. There is no universal mask. And you have to, the mask also comes with a lot of accessories like your harness, your chin strap, your oxygen connector. A lot of accessories also comes with individual mask. So yeah, not only the interface, but the accessories are also important. As I said, we have to select a proper type of interface and the proper size. Some comes with a device to select a interface size. But practically it can be selected by most of the user. It is not a very difficult one. Only thing is the availability. Sometimes a patient who comes with a very large face and you do not have an extra large oronasal mask, then you find it very difficult. So another thing which I want to make a point here is the 2 things which is more commonly used in COVID-19 NIV uses, that is oral nasal mask as well as the hood. There are a lot of studies going on between which is superior and which is not. Most of the authors are at this current point prefer oronasal mask to start with. Again, when we look at the oronasal mask, they are of two types. That is, one is called vented, another one is called non-vented mask. Why so? You look at this, as I said, the ventilator can deliver the air by a single limb or by a dual limb. So all the portable BiPAP machines generally gives the air to the patient by a single limb. So what will happen to the expiration? How the expiration will happen? It has to go to the atmosphere. That is why that mask has to have a vent. That is why it is called vented mask. But when you have a double limb circuit or a conventional ICU ventilator, you have to have a mask which has no leak or no vent. So this is what is vented mask, and this is how the non-vent mask looks like. So we have to simply remember that vented masks are for single limb circuit, non-vented masks are for double limb circuit. What is the difference between these two? You have a unidirectional valve which is situated here, which will allow the expiration to happen to the atmosphere. Now, how do we initiate after selecting a device, after selecting a proper interface? What we do is the initiation of NIV. The first step of initiation is explain to the patient, because it is not a natural thing which we are going to the patient. You are doing it to a conscious oriented patient. That is what is the indication for this NIV. So we have to explain the patient, we have to get the consent, and you have to talk to the patient what is going to happen, and slowly you have to do. So first thing you have to do is select a mode. The first two modes which I mentioned is CPAP and pressure support. CPAP is continuous pressure, positive airway pressure, and second one is pressure support ventilation. These two are spontaneous ventilation, and the other two is pressure control ventilation and dual modes. They are not very commonly used. If you want to use that, you have to learn it in depth, because they are control modes, and it can only be mostly used in conventional ICU ventilator, not with the BiPAP machine. So more and more what we understand, and there are papers are also coming out, the COVID patients are mostly required in the early part of the disease. They will be requiring only a continuous positive airway pressure, a separate pressure, that is, we call it as pressure support ventilation, and the requirement is very less, unlike in a COPD or asthma patient where we require pressure support ventilation. We will not go into detail of that, but we have to remember that there is two modes which generally commonly used, that is CPAP and pressure support ventilation. So I'll just give you an example. What are the settings we generally do for a pressure support ventilation? The first thing is we should set a PEEP. In a portable ventilator, we call it as a expiratory positive and airway pressure, and then pressure support. What is the additional pressure which will be applied during inspiration? And that is also known as inspiratory positive airway pressure in a portable. So the term PEEP and PS, you can be different. PEEP and PS is used in ICU ventilator. EPAP and IPAP is generally used in portable ventilation. What is the difference between these two? The pressure support is IPAP minus EPAP. And you have to have a backup rate. Most of the portable ventilator also allows some amount of backup ventilation, but that is not perfect, but some amount. Then you have to have a trigger setting, either pressure or volume. Then you have to set a rise time. Then another interesting thing, it is a spontaneous ventilation. Pressure support ventilation is a spontaneous mode. I have highlighted IE, that is inspiratory time and expiratory time. We cannot precisely regulate this, but you have methods to regulate this. And we have to give some importance to that, because this sometimes leads to asynchrony. So how do we set? Generally, they will give you a setting like TI minimum, TI maximum, or expiratory flow settings. So this device to device will vary, and we have to focus on that. Then the ramp times. The ramp time is a time by which slowly the pressure will build, and the other alarm settings. This is the IE settings which you can adjust. I've just represented a graphics picture, but I'll not go into detail of that. Now, once we initiated the ventilation, we have to monitor what is happening. So now we have put the patient on non-invasive ventilation, a respiratory support. So we have to monitor. What are the things we need to monitor? We need to monitor the patient, we need to monitor the ventilator, we need to monitor the interface, and the clinical parameter, which is coming in the bedside monitor, a lab investigation like ABG. So patient, the first thing, the patient after initiating the NIV, the patient is comfortable, conscious level is good, it has improved or not, chest expansion is good, accessory muscle usage has come down or not, synchrony is there or not. Interface, what we have to see is a leak, or sometimes it is very tight fitting mask also is very not good. Trigger, volume delivered, cycling, then the cardiovascular system, respiratory mechanics, if the parameters are coming either in a graphicals or digital format, we have to look at that. Then we have to do a lab investigation like IBG. And we have to do it in a, the clinical parameters are done generally continuously, which is coming in our monitors and ventilator. But other objective parameters has to be assessed in particular time interval. 1 hour is very important. When you start initiative NIV, after 1 hour, you have to reassess either your NIV is helping or not. If not helping, can you do something with the settings or not? If not, then we have to consider other modality like invasive ventilation. The 1 hour time frame, sometime some people wait for 6 hours, but 1 hour, 6 hour, 12 hour, you can have your localized protocol. But anytime you change, again, you have to start back. Like you have changed the setting, you start again 1 hour ago. After 1 hour, you have to see if your change in setting is helping or deteriorating the patient. So that is more important. So why should we monitor? Because we have to see either our NIV is adequate, or there is a failure of NIV, or there is a complication which is being which is happening because of our NIV. Now, how do we know that our NIV is adequately helping or it is failing? It is mainly done in clinical as well as some bedside monitoring and lab monitoring. Just to put it in 3 simple parameters, that is, you have to look for the work of breathing, you have to look for the oxygen, adequate oxygenation, then you have to look for the other system, and most 2 important system is CVS and CNS evaluation. If these 3 systems are better when you before starting NIV and now it is parameters are clinically better, then you know that it is adequate. If it is deteriorating, that means it is not adequately supporting. But to have an objective parameters of each of these 3 things, we can have non-invasive, already log ROX index has been talked by my previous speaker, that is being developed for high flow oxygen therapy. But the same thing is being now used in by many people when you do not want to do a frequent ABG and you want to have a simple parameter. So a value of less than 3.84, you should be careful. Now, another thing which 5 years back, Duan et al. Published, they call it as a HACOR score, where they have taken into the heart rate, acidosis, consciousness, oxygenation, and respiratory rate. And they put that any patient who is having more than 5, a score of 5, it is very highly sensitive and specific for imminent intubation. They have done it for 1 hour and 6 hours and 12 hours. So other people are also investigating it. So it is one of the objective parameters. In a recent publication, which is there in BJ, Battaglini et al., they have proposed a complex objective parameter, which will tell you that if the patient is, they have taken this HACOR score, they have taken a COVID-19 score, they have also taken the ROC scoring, and then they have formulated. So this is evolving. So what should we do? When should we shift to from non-invasive to invasive? We have to purely go by the classic recommendation. If your work of breathing is not addressed by non-invasive ventilation, oxygenation is not happening, and your cardiovascular system and CNS is not improving, then better you go for invasive ventilation than wasting time in non-invasive, precious time in non-invasive ventilation. Now, once we connect, we should know that we know there is a lot of problem because we are using a machine. You can go for, we can have trouble. So you need to have a troubleshooting. So what are the trouble points? It can be from the machine, it can be from the interface, it can be from the patient end. And the most common, few common troubles which I have pointed out here is intolerance, leak, inadequate ventilation, hypoxia, hypercarbia. And how do we solve this? Few only I pointed out. If patient is intolerant, you have to counsel the patient. You have to see if it is required or not. Sometimes the patient may not be requiring a non-invasive. You are forcing non-invasive, and then that is why patient is not tolerating it. If there is a leak, you have to adjust the mask, you have to change the mask, you have to look for the accessories, adjust the ventilator setting, and most importantly, consider invasive ventilation if indicated. Now, the most common thing which happens with non-invasive ventilation is leak. So we have to identify the leak site. Again, the leak can be divided into two parts: intentional and unintentional. Unintentional is which you do not want. We know that when you are applying an interface, non-invasive ventilation is bound to happen, bound to have some or other type of leak, which we call it as an acceptable leak. That is why most of the machine calculate the leak and compensate for the leak. Leak compensation is there. But if it is too much, then we can have problem. We can have problem with the triggering, we can problem with the ventilation, we can problem with the cycling, we can have problem with comfort of the patient. How do we troubleshoot it? Again, you have to adjust the interface, locate the leak site, ventilator parameters you may have to adjust. And the last but not the least, you have to think if that pathology has progressed. Sometimes what happens is we put the mask, we tightly fit it, and the patient is ventilating. What happens is we have put it in auto mode, the patient compliance has decreased, the pressure is increasing, pressure requirement is 20, 25, and because of the high pressure requirement, there is a leak. So previously leak was not there, now leak is coming. In spite of adjustment of interface, you should be again looking at the compliance and resistance component of the patient. If there is any pathological changes has happened, that has to be addressed. Humidification already being pointed out. I'm not going to go into detail of that, but what is being recommended, which we should do, is active humidification. HME is inadequate for humidification, particularly in NIV ventilation. But most of the time, because of lack of manpower, lack of resources, we go for HME. But that is not a very efficient method to do humidification when we are using NIV. Now, once we have put the patient on NIV, how do we wean the patient from NIV? Or weaning is a method by which we disconnect the non-invasive ventilation thing. Once the pathology is resolving, the patient is improving in terms of pathology, patient is comfortable, respiratory parameters are acceptable, non-invasive requirements are decreasing, CPAP requirement is close to 5-6. And we can have our local protocol-based weaning, or we can have a clinical assessment. So protocols are differing from institute to institute. A simple thing which I can say is look at the oxygen requirement of the patient and look at the CPAP requirement. The pressure, continuous positive airway pressure requirement somewhere around 5-6. Oxygen requirement can be a little higher in COVID patient, but if the CPAP requirement has come down, what you have to look, if the patient is requiring both oxygen and a minimal amount of CPAP, 4 to 5 or 6, as my previous speaker has pointed out, the CPAP is capable, HFNC is capable of delivering a CPAP of 3 to 7. You can use switch from NIV to HFNC. It is a more comfortable device, so you can switch. But if it is only oxygen is required and there is no positive pressure is required for the patient, you can use other oxygen delivery device like mask or other device, and we can wean the patient from non-invasive ventilation. Now the complication, there is a lot of complication can happen. I just want to point out few. One of the most common complication, this is, I'm listing as a complication. It is not a complication of NIV, but it is not taking a decision of going for invasive ventilation from non-invasive, which is causing the problem, because there is a non-invasive ventilation is going on, some amount of oxygenation is happening, and patient is conscious oriented, though the workup breathing is very bad, respiratory rate is 40-45, and still we go ahead with non-invasive ventilation because of logistic and consent issue, that worsen actually the prognosis. Then this is where patient suddenly will desaturate and the cardiac arrest can happen. And because of high pressure, more than, if the pressure is more than 25, patient can have a pneumothorax, pneumomediastinum. Even in the lower pressure, we have seen a lot of pneumomediastinum, pneumothorax, because of the sheer workup breathing. A lot of negative pressure is being generated by the patient. And in combination, the total pressure is increasing, and pneumothorax, pneumomediastinum, we have seen a quite good number in this pandemic. Aspiration is a real possibility, and hypotension is there when you're using a lot of high pressure. And this is what is the most common sight in most of our ICUs when the patient are continuous NIV. The local ulceration, even we have seen deep ulcer, erosion to the bone because of continuous use of NIV. Another thing which we have to be very careful is Atrogeny. So if your settings are not proper in non-invasive ventilation, you can cause volutrauma, you can cause barotrauma, and the oxygen toxicity, which I have just put it as a oxytrauma. So if you are not titrating based on your, like oxygen saturation has reached to 98, 100%, and still you are keeping 100%, because these devices are very efficient oxygen delivery device. If you set 90% or 85%, it is delivering 85%. So continuous higher oxygenation is a problem. We know that the target oxygenation is only 92 to 94. And low compliance setting, you have set a pressure support very high. What happens? The patient is getting a tidal volume of 800, 900, but most of these ventilations are going to physiologic dead space. Rate is very high, so patient is going for volutrauma, barotrauma. So we have to evaluate, we have to adjust the ventilator. If you are not doing this, we are creating a iatrogenic complication. So to complete, I just summarize what I was trying to present in my last 20-25 minutes, that NIV is more often used now in COVID patient. But what is more important is patient selection, close monitoring, troubleshooting, and right strategy increases the success. For that, we need to individualize our NIV strategy for that particular patient. And explaining, talking to the patient is very, very important. And interface, better to start with a oronasal mask, then switch based on the different interface which you have and which is suitable for that clinical condition and the patient type. So as I have already mentioned, the appropriate mode, what pressure you should be ventilating, either the CPAP is enough or you need a little bit of pressure support, or in very difficult case where patient is not giving consent for invasive ventilation, you can go for even a control mode like pressure control ventilation. But that is a little, that is a different thing which you have to discuss in detail. Then either you have to set the flow or what flow, all the settings you have to know. You have to know what device you are using, what are the settings, and if you alter those settings, what happens to the breath delivery. Then you have to very closely monitor both subjectively clinical parameters and objective parameters. As I have mentioned in my last slide, avoid iatrogenic complication. But last but not the least, the most important information I want to reiterate again is do not delay invasive ventilation. Thank you.
Thank you so much, sir, for appraising us about the NIV use in COVID-19. Also pointing out how the monitoring of the NIV is important while we are starting with the non-invasive ventilation. Thank you so much, sir. Heading towards the next lecture, I would like to invite Ms. Madhura Gauri Shevade, Associate Vice President of IARC and the Co-Vice Chair of Indian Academy of Respiratory Care. She is the Associate Editor of IJRC. Madam has done her MSc from Rush University College of Health Science, Chicago, USA. Madam has more than 10 years of experience in her field. Madam has several publications to her credit. I request Madam to kindly begin with the session. We welcome you, ma'am.
Thank you, Ms. Hemlata. Thank you so much for the kind introduction. Let me begin by thanking everybody for letting me be a part of this e-course that we are having today. I'm extremely honored and extremely privileged to be amongst the best in the country. What I'm going to talk about today is aerosolized medications in COVID-19. And I think this is one of the simplest, yet one of the most difficult presentations that I would be giving today. So let me begin without further ado. All right. So before, as the other authors have mentioned their disclaimers, my disclaimer for today is I have no conflicts of interest to disclose. I have no financial benefits from the talk since I'm going to be talking about various devices, aerosol devices. All the images that I have taken are from the internet, and if I have taken some from any publication, I have cited them correctly. I have tried to compile my best, to compile all the data that has been that is coming out since day one of COVID. But however, your practice slightly may vary because there have been, lack of resources, or the protocols may slightly vary. So what I have done is try to give you an overview of it. And before I begin, I would like to also say, I know I am amongst the best, some of the best chest physicians of the country here. So I know that if I make some mistake, if some error, I know they are here to correct me. So I welcome that. So what I'm going to talk about today, as I said, is aerosol therapy. Now, aerosol therapy, why is it special? So COVID-19 has been, a burden to us since last year, and it's nothing but an infectious disease because of the newly discovered coronavirus. It is a highly infective disease which spreads through the droplets of the infected person through close contact, airborne, as well as fomites, surfaces, etc. And it does affect the lungs of the patients. What is aerosol therapy? Aerosol therapy is a delivery of inhaled aerosolized medicines through inhaled devices that can be given for pulmonary diseases. Why is it important for us to understand? Why is it important to know about aerosol therapy, one, and why are they given in COVID-19? Well, aerosol therapy, a therapy per se, it's very safe. You can safely deliver and you can safely give it to your patients. It acts fast because what we are trying to do is we are trying to target the organ that is affected through aerosol medicine, and in this case, of course, it's the lungs. So whatever drug we give to the lungs, it's going to start working on it right away. It's very effective. You can get a high effect through aerosol therapy, and of course, it requires very low dosage of drug. Now, this comparison is done in terms of oral therapy. So that's why it's a very important and very the best therapy that you can use for your patients. Now, for COVID-19, of course, there are other therapies. I don't want to get into the details of those, but of course, we have a huge number of COPD and asthma patients in the country, and we cannot forget them. These patients, when they come to us with COVID, of course, they will need to continue with their inhaler device therapy, right? So for them, nebulization, inhaler therapy is something that will be given. Of course, when we need to look into the inflammatory mucus production aspect of the disease, and we need to relieve and give some relief in terms of breathlessness to our patients, we definitely can use aerosol therapy. Apart from that, aerosol therapy specifically is used for bronchodilation, as I've just mentioned, for asthma, COPD. If there is a patient whose ventilator has increased airway resistance, there is some air trapping that has happened. For all these reasons, the patient is not weaning well. Also, if you need to deliver some sort of a specific medicine, for example, in case of cystic fibrosis, or you want to give an antibiotic to the lungs, inhaled antibiotic, you can definitely make use of aerosol therapy. Now, what type of drugs are given? Now, this is a list of drugs or medicines that are available in India, which can be given through an inhaler format or nebulizer format. These are categorized based on what they do, of course. So we've got bronchodilators, you've got inhaled corticosteroids, you've got a combination of those. You can also give mucolytics, which help loosen the mucus that is blocking the airways, antibiotics, as I just said. And there's new research in terms of inhaled insulin and surfactant therapy as well. So you can consider using these for that. Now, India, as I keep on saying this, and I will never stop saying it, but India is blessed when it comes to the number of devices that are available for excuse me, our patients when it comes to inhaler therapy. These are the different categories, and all of these devices are available in India at a much cheaper rate compared to the Western world. But then when it comes to COVID, can we use all of these? Should we use all of these? Research is coming out every day, and although we know how to use all of these, and our patients know how to use these, there are certain criteria, certain points that we must remember when we are using them. So to begin with, there's some concerns, as I just said. Aerosol therapy. So the biggest concern or the biggest challenge for management of COVID-19 has been aerosol generating procedures, and the way to prevent it, the way to control it. Now, all of us know that SARS-CoV-2 is spread through droplets, through the person's breath, through the person's cough, when he comes in contact with the other non-infected person. Now, aerosol therapy, there is an increased risk of transmission because the aerosol dispersion distance is high, as our previous speakers have mentioned. That's why it is very, very important for us to follow proper guidelines in terms of the use of aerosol therapy, using the correct device, because there's no point in giving the wrong therapy if it is not going to be effective for your patient. And of course, using infection control measures. Now, with that introduction overview, I will quickly move on to what is it that I'm going to talk about today. Very simple. One is I'm going to talk about the few types of devices that have been used for the past 14 months, and you can use them in your clinical practice for COVID patients, as well as some scenarios where you can use these devices. So let us look at your pressurized meter dose inhaler. Everybody knows the inhaler, the pump, which basically, as the name says, it has a metered dose canister, which has all the doses. And when you press on the canister, the first dose is delivered. For COVID patients or for any asthma, COPD, any guidelines that you look at, it is always recommended that you use it in combination with a spacer, or a non-static valve spacer, or a non-static valve holding chamber. Why is it? Because there are a lot of coordination issues, there are a lot of other issues that arise when you use your pressurized, just the inhaler itself. Those are nullified, or those are reduced drastically when you use it in combination with your spacer. So the biggest one is you get more deposition of the drugs when you use it in combination with your valved non-static spacer. And of course, any side effects that you may have with the medicine sticking to your throat, etc., that is reduced very much. The other type of device that you can use is your dry powder inhaler. Again, as the name suggests, it's a type of a device that delivers dry powder form of drug. Now, this drug, which is very small in size, is attached to another molecule, which you basically later on swallow. Typically, it is a lactose molecule. What happens is when you inhale, or when the device is activated per se, there is a mesh. Typically, there is a mesh, if you can see here, something here, that sort of helps separate the two parts together. And the tiny molecule of your medicine goes to the lower part of the lungs, and the lactose molecule is lactose. So it basically sticks to your throat, and you can or you can swallow it, just goes to your stomach. And that's how this device basically works. And the third type is your nebulizers, which are widely being used in our country. Now, again, with exclamation, I would tread lightly, and I would say you may be able to use a jet nebulizer or a small volume nebulizer. What this device basically does is high pressure air is passed through, or oxygen compressed is passed through the device. It is a cup which contains the liquid form of the medicine, and the combination of that liquid form with the high pressure air sort of breaks down into aerosol particles that are basically given to the patients. But what is recommended, and which is more effective and efficient, is your vibrating mesh nebulizer. Vibrating mesh nebulizer basically has a small mesh which has tiny holes in it, and when you put your liquid medicine on top of it, it vibrates, and that vibration creates tinier aerosol particles, which are basically given to your patients, like in a mist format. So what can you use for your spontaneously breathing patients, aerosol devices? So the very first thing is what I have read from all the articles so far. For a spontaneously breathing patient, if he is able to use it correctly, using a PMDI with a spacer or valve holding chamber is the best thing that you can do for that patient. The other thing you can use is a dry powder inhaler. But for the dry powder inhaler, you have to ensure that the patient is able to generate that high inspiratory flow rate that is needed. If the patient cannot use these devices, or their formulation is not available, then you may consider having your patient use a jet or a mesh nebulizer. But you have to always remember that you should use a filter when you are using a nebulizer, and always use a mouthpiece. The mouthpiece helps, it increases the delivery, and of course the mesh, the filter helps in reduction of how much of the aerosol particles are gone in the contaminated aerosol particles are pushed in the air. How can you use aerosol delivery through high flow nasal cannula? Now HFNC has gained a lot of momentum in our country. It has been for the past few years, but for COVID we are seeing a lot of positive response. However, there are certain things that you must remember. So a vibrating mesh on the dry side of your heated humidifier is the best when you are using HFNC for your COVID-19 patients. Remember that whatever prongs that you are using for your patients, they are fitted well, and after you have placed those prongs, ensure that there is a mask on top of those prongs, especially during the aerosol delivery procedure, so that whatever is exhaled, this is basically to avoid or to lessen the spread of the aerosol particles in the air. Now, I will not go into the details of it, but there is some research that has done recently. So if there are any clinicians who are listening to me here, who are more experts probably than I am in HFNC, there is research that has shown that if you lower the flow rate of your HFNC and deliver your aerosol therapy only that 15-minute duration, that will give you more deposition in the lungs. But there's a big disclaimer here that only if your patient can tolerate it, you can consider going down the flow rate to 10 liters per minute, only for the duration of the aerosol therapy. And after that, ensure that the flow rate is turned back on to what is needed or what the patient previously was on. But this, I would suggest, this should be done under the supervision of a respiratory therapist or a physician who is at the bedside and watching the patient for any adverse effects. Of course, if the patient is not able to tolerate, you should just go ahead with the flow that the patient is on. How or what do you do, or how can you give aerosol therapy to somebody who is mechanically ventilated? The goal for mechanical ventilation is to ensure that the circuit is intact so that there is no spread of infection. Now, this is applicable to non-invasive as well as invasive ventilation. And as Dr. Tripathi sir has so brilliantly explained to us in the previous presentation, you should always try and use the double limb with the non-vented circuit for avoiding infection. Of course, as I just said, you should avoid leaks. And the best is you should use a vibrating mesh nebulizer when you're using it with a humidifier, double limb circuit, and a filter at the end. Now, aerosol therapy, see, if you do not have a vibrating mesh, and or if you have but there is nothing left but you have to use a jet nebulizer, I would suggest that it should be done with clinical judgment, and of course, because of device availability, you may be able to use it. How? Now, there is research. I am not sure if this is available. Jet nebulizers are available in India, but what is recommended recently is you use it with a T-piece that has a valve in it. I'm not sure if it is available yet here, but this is another way that you can use it for your patients. Again, ensuring that you don't break the all the time, and of course, the patient is not deteriorating because of it. So what are some recommendations now with this background? This is, again, you may use this, you may use that, but what are some good recommendations that are out there for your patients of COVID? One is try and use aerosol therapy only if it is absolutely necessary. Don't unnecessarily have your patients on nebulizers just because you feel they may be able to benefit from it, if they are doing well. Of course, I don't know if the previous presenters have already mentioned this, but especially during the aerosol generating procedures such as this one, is a must. Always use your droplet, your infection, airborne, all these precautions. The more prepared you are, the better. You should, as I said, try and use your PMDI with spacer. It has more benefits if the patient is able to do it well. Use filters and mouthpieces when you're using nebulizers. If the patient is in a single room, make sure that you close the door, you walk out of the room, and you stand outside at least, so that you are not exposed. The constant exposure is lessened. If there is a family member, you can ask them to step out for some time. You can do all of these things. If not, then you have to ensure that you maintain at least a 6 feet distance from your patient. As I said multiple times before, closed circuit is the best, and you should try and use that. Try and not break the circuit for two main reasons. The first reason all of us know is you don't want to let go of the pressure that is created, that is holding your patient's lungs open, of course. And the second is you don't want the infection to spread in the atmosphere in wherever the patient is present. And of course, you should always use a filter. Try and use it as and when you can. If the patient is in a single room, if the hospital has a setup of a negative pressure room available, make sure that your patients are in the negative pressure room. If not, try and have HEPA filters everywhere. I'm sure all the hospitals have HEPA filters. Make sure that is available. But I know for our country, there may be places, there may be times where we don't have the privilege of privacy, especially the last couple of months when we saw so many patients, we had to manage them all together. In that case, at least, have some curtain drawn around them. Make sure that the distance between the two patients is 1.5 meters. Try as much as you can. So the goal of aerosol therapy is to administer the drug that is needed, the necessary therapy that is needed, but to be able to do it with the utmost precautions, so that the spread of infection that you may likely do or give because of the therapy is lessened. Again, this is a clinical judgment aspect, because using the device is one thing, what you should do and shouldn't do is another thing. But the need of the patient, nobody will know that except for a clinician, except for a healthcare professional. So you have to find that balance between the two. So with that, I would like to thank you all for listening to me. There is a lot that is still being studied on aerosol therapy. I know there are different strategies that have been used by all of us in the last few months, last few years, a couple of years, I'm sorry, which have helped or haven't helped our patients. But these are some of the tried and tested things that are out there. And I hope that all your patients benefit from whatever you are learning and you're taking from us from there. And of course, all the best to all the students who are listening to me. Thank you for listening. If you have any questions, please put it in the chat box and I will answer them in the Q&A section. Thank you so much.
Thank you so much, ma'am, for appraising us about use of aerosolized medication in COVID-19 patient. Now moving towards the last session of today's e-course, that is a panel discussion. I'm delighted to invite our moderators for the panel discussion. Very first, I would like to invite Dr. Lokesh Kumar Saini, Assistant Professor, Pulmonary Medicine, AIIMS Rishikesh. Sir has done his MBBS from SP Medical College, Bikaner. Sir has many publications to his credit and presented many papers in various national and international conferences. He is an active reviewer of multiple national and international journals. Presently, sir is conducting multiple funded intramural and extramural projects. I welcome you, sir.
Thank you.
For our panel discussion, our next moderator is Ms. Kisha N. Shakaria, Vice Chair at Indian Academy of Respiratory Care. Madam is a respiratory therapist specialized in neonatal and pediatric respiratory care, graduated from Manipal Academy of Higher Education. Madam has served as a faculty at MAHE since last 6 years. Currently, she is the Director of Respiratory Care at Kannad Hospital, Al Ain, UAE, and also the Vice Chair of the Indian Academy of Respiratory Care. I welcome you both. The theme for the panel discussion is multidisciplinary respiratory care in COVID-19. I request you to kindly proceed with the session. Thank you.
Okay. So let us start the discussion with an introduction of our panelist. In this panelist, we have two panelists from our institute, my institute only, from AIIMS Rishikesh. If Madam is there, yes. So one is Dr. Vasanta Kalyani, Madam. She is PhD, MSc Nursing, MSc Psychology. She is currently the Principal and Associate Professor in Department in the College of Nursing in Rishikesh. Madam has more than 22 years of experience in nursing education, service and research, chapters in nursing books. Madam is editorial and reviewer of various national and international journals, and she is also executive board member of various universities. So I welcome you, Madam, in this panel. Ma'am, please unmute yourself. Please, we cannot hear you right now. Okay.
Thank you, sir. Thank you.
Next, we have Ms. Surbhi Tablial with us. She is Masters in Physiotherapy in Cardiopulmonary and ICU. She is working as a physiotherapist in Department of Physical Medicine and Rehabilitation in Rishikesh. She has done her Masters of Physiotherapy from Swami Rama Himalaya University, Dehradun, Uttarakhand, and she has spoken in multiple regarding multiple role of rehabilitation in COVID-19 patients in different state universities. So I welcome Surbhi also. Surbhi, are you there? Yeah, you're here. Okay, so for next introduction, I'll like to invite Ms. Tisha to introduce the rest of the panelists.
Thank you, Dr. Lokesh. First of all, it's a privilege and honor to be part of this panel discussion today, which is collaborated by AIIMS Rishikesh and IARC. A great achievement for IARC indeed. So we have three more panelists, and I would like to introduce our first of the next three is Dr. Vivek Kumar. He is a graduate and postgraduate from Armed Force of Medical College, Pune, and he has specialized in internal medicine. He has completed his DNP in internal medicine from National Board of Examination. He has certifications of IFCCM, EDEC, and his research published specializations are in intensive care echocardiography, long-term mechanical ventilation, COVID-19 infections, and he has more than 20 indexed publications in national and international publications. He is a fellow of Indian College of Physicians, American College of Physicians, and Indian College of Critical Care Medicine. Currently, Dr. Vivek is working as Additional Director of Critical Care and Emergency Medicine at Sir H.N. Reliance Foundation Hospital and Research Center, and is the clinical lead for a 650-bedded COVID jumbo facility at NSCI Rowley. Welcome you, sir. Okay.
Thank you.
Okay. Our next panelist is Mr. Daniel Rowley. Most of them call him Dan, and he is a postgraduate. He has done his RRT in ACCS and NPS, and he is a fellow of AIARC. He is an adult clinical coordinator in respiratory therapy, and he has 28 years of practicing respiratory care to his credit. He is currently the president of International Council for Respiratory Care. He has been the chair of Virginia Legislature Board of Respiratory Care and currently holds advisory and committee positions on national and international committees related to respiratory care. He has multiple publications to his credit, and he's a known face to conferences around the globe. Welcome, Dan. Are you there with us?
Yes, I am. Thank you very much.
You're welcome. Yeah. So our next panelist is Mr. Akash Soni. He is a graduate and postgraduate in respiratory therapy, and he has done it from Symbiosis International University, Pune. He has several years of experience in respiratory care, and he serves as a senior RT at Raheja Hospital, Mumbai, which was commissioned as a COVID critical center when the pandemic started off. And he's also associated with Symbiosis University, Pune as an adjunct faculty of the Respiratory Therapy program. He also holds position of General Secretary of the Maharashtra chapter of IARC. Akash, welcome. Are you there?
You have to unmute yourself, Akash, first.
He's there?
Yeah, I'm here.
Okay, that's great.
Yeah, thanks for the introduction.
Welcome. So we have 5 people with us, and our topic for today is multidisciplinary respiratory care in COVID-19. As we had a very good inaugural ceremony and the talks, which just reinforces that, we need to be multifactorial, we need to be multidisciplinary, and we need to reinforce our team to kind of cater to the needs that is demanding nowadays. And we don't know where the road is leading to us. So I would like to start this discussion with Dr. Vivek. Okay, so we have seen COVID patients present to us so differently, and they present at different phases of the disease progression, and also with different phenotypes, and they present again differently to us. What has been your approach and strategies to a patient with respiratory distress at the ER?
Can you just repeat the last line, please? What has been your approach?
Of a patient with respiratory distress that presents at the ER.
So I think the most important time is the most important point in history is the timeline. So it is how many days from symptom onset. So if you are in the first week of symptom onset, well, probably it's a rapid disease progression, and we are looking at something like a primary viral pneumonia, which is extensive and bilobar. If it is in the second week of illness, well, from the symptom onset, we are looking at something like a cytokine storm. If it is in the third week of illness, and well, then we are probably looking at more closely at a picture of underlying lung fibrosis. Now, between the 3 weeks, things are not crystal clear, like, day of first week, second week, third week. But typically, anywhere in the 3 weeks, they can come in with venous thromboembolism. And anywhere in the 3 weeks, they can come in with the acute coronary syndrome, typically acute myocardial infarction. Now, when we look at the patient phenotype, so if I have a clean patient, a young person with no comorbidities, and on the other extreme, I have an elderly or I have a person with multiple comorbidities. So obviously the people with comorbidities have less of a cardiopulmonary or any physiological reserve in the body, and they pack up pretty early. So people with comorbidities may precipitate with breathlessness in the very first week and may not be having such extensive disease. So when we look at breathlessness in the first day 1, 2, 3, 4, 5, 6, 7, then we image the patient, and once we image the patient, we do confirm that it is a primary viral pneumonia. It is unlikely to be anything else. We do send in the inflammatory markers. Most of the time, inflammatory markers are not raised in the first 5 days. Yes, day 5 to day 7, they may be borderline high. In the second week also, when the patient comes in with respiratory distress, we troubleshoot, we do the imaging. The imaging can be an X-ray chest, a bedside lung ultrasound, or a CT scan if required. We send in the inflammatory markers. Typically, they are raised and the patients are in a cytokine storm. But then, it's a heterogeneous disease. There are patients, I say, with bad X-rays and low oxygenation, and then there are patients with good X-rays and low oxygenation. So if you have a patient phenotype with good X-rays and low oxygenation, and the inflammatory markers are not raised, well, typically this subset may be a vasculopathy or what we know as an endotheliitis. In these patients, we quickly send in the D-dimers along with the inflammatory markers. We do the lung ultrasound and we do the DVT screening. Most of the times, the disease is not there in the lungs and the DVT screen is negative and even the D dimers are not raised, but they are profoundly hypoxemic. If possible, and if facilities exist, we send them for a CT pulmonary angio. And if not, and then we come to a clinical differential, well, it is a vascular disease related progression, something like a, diffuse pulmonary microangiopathy, for which beyond this, we cannot do any other workup. Moving from the second week to third week, one differential, of course, is that there is disease progression and there is fibrosis. And for this, again, at the bedside, we make it out by doing lung ultrasounds. And also, if the patient is intubated and ventilated, we come to know the lung mechanics, especially if the compliance is extremely reduced and the pressures are very high. So we know he's heading for stiff lungs. But the other differential which comes in the third week and definitely in the fourth week is it a secondary bacterial or a fungal super infection? And then we do target that. So this is how we look at, and our therapeutics are very clear. In the first week, they go in for antivirals. After day 4, they go in for steroids, prophylactic dose of anticoagulation. In the second week, of course, now early, if there is a vasculopathy, of course, in this forum, we are definitely using a drug called bevacizumab, which is not approved, but which has got extremely good results when patients are going from 0 to 4 liters or 4 to 15 liters very fast. It acts on the vascular endothelial growth factor, and patients do come down on their oxygen support extremely rapidly from 15 liters to 2 liters over the course of next 48 hours. Probably we'll be publishing it as a retrospective analysis, but the drug is safe. As a clinician, I cannot endorse it, but it just goes on to prove that there is a component of a vasculopathy. If we are in the cytokine storm and the patient has received 48 hours of therapeutic steroids, we try to blunt the cytokine storm. We use doses of tocilizumab, but unfortunately of late it has not been available. We've used an alternative called itolizumab, but then there have been, the patient tolerance is not so good. And definitely we find that these patients are more vulnerable to secondary sepsis. If the lungs are getting fibrous, well, there is nothing we can do. We do continue the steroids at a lower doses. We have not come to a consensus, but the evidence is against the use of pirfenidone or any of these agents as such. And we do not have a trial in which we are enrolled for this. For super infections, we have kept our antibiotic policy very simple. If we have patients who are clean at admission and they are going on to steroids, we may probably, and they have a moderate disease to severe disease, we start them with the augmentin. But if we are escalating on the steroids and going on to immunosuppressives, we take them on to piperacillin tazobactam. However, if a patient comes from community who's got comorbidities and who's got pre-existing organ failures, who's had recent admissions where we suspect that there are community-acquired MDR bugs or MDR bugs which the patient is colonized with, we do start with the piperacillin tazobactam when they are in the moderate phase of the illness. And if there is disease progression and if there's evidence of further infection or a super infection, then we step it on to probably, I will say, a non-carbapenem based regimen, because we found a lot of carbapenem resistance and infection control has been a huge problem. So this is how I approach. My weapons are very clear. The protocol, any respiratory distress, look at the SpO2 properly, see that the probe is properly placed, see that you are getting a good plethysmographic waveform, see that there is a blood pressure, go in with the ABG, do the SpO2 FiO2 ratio, take the RR, calculate the ROX index, because we also love to teach. And of course, quickly rush in with the lung ultrasound, see whether the B lines are sliding. There is sliding of the pleural line on both the sides. That is good. If you have thick pleural lines and if you have shaggy pleural lines, you have broken pleural lines, probably it's advanced disease and this patient will definitely head for some form of ventilatory support. If you have a lot of B lines, well, there may be some fluid, but in all probability, if you have a lot of B lines with thick and broken pleural lines and see patterns on lung ultrasound, this patient has got advanced disease. Quickly do a echo and rule out RA-RV dilatation and a proximal DVT screen to rule out venous thromboembolism. Now, in the second, and then follow it up with the X-ray chest, and if facilities permit, a CT scan. The last thing I want to say is we've done a study also, and there is an incidence of spontaneous pneumothorax. We've had it once on NRBM, 15 liters per minute. We do see it on NIV. We've not seen it on HFNC so far. And on invasive ventilation, well, I would just like to say PEEP doesn't help in all patients. Be very clear. In the first week, you can recruit the lungs maybe. In the second week, pray and then do the recruitment recruitment maneuver. In the third week, never recruit. And if you are having a super infection, I think it go by the lung mechanics. I mean, I will prefer not to recruit the lungs. So I will say just individualize the PEEP. High PEEP doesn't help at all. Thank you.
That's a great insight, sir, and a very holistic one. Thank you so much for your inputs. I would like to move more, as you said, it differs, non-repeating mask, high flow, and NIV. You should be very selective in what phase you're going to choose it for the patient. Dan, I would like to bring in you in this at this moment for getting your experience on introduction of HFNC or non-repeater mask. What is your practice been like, and what is your experience during this pandemic from the ER?
From the emergency room, excellent. Yes. First of all, thanks for inviting me to be among this excellent panel of experts speaking on your symposium today. I do work in the emergency room frequently, and during wave one, where we didn't know a whole lot about COVID, of course, we were trying to avoid non-invasive ventilation and high flow nasal cannula, as many of the presenters had pointed out. Now that we're in wave 3 and we're starting to see an increasing number of non-vaccinated patients come into the emergency room, we are once again becoming busy in my emergency department. So my experience is that when a patient comes into the emergency department, I'm getting on my PPE immediately. We're limiting the number of people who are in these airborne infection isolation rooms, because we're likely going to be performing some type of aerosol generating procedure. When I walk into that situation, we have patients presenting with profound hypoxemia. So my immediate goal, of course, is supplemental oxygen. Oftentimes they're at this point on a non-rebreather until I can get them over to a high flow nasal cannula or non-invasive ventilation if they don't need to be intubated. During my assessment, of course, one of the things that I like to do is assess their work of breathing. Of course, patients can remain tachypnic, but as long as they don't have high workload, meaning accessory muscle flexion, they can actually be managed for extended periods of time with these non-invasive approaches. And then last but not least, I immediately now encourage self-proning. Once we get the patient on a monitor and they remain hypoxic, self-proning is a very big early intervention for us.
Okay, that's great. So it's prone with HFNC, and if the time is delayed, you use a non-rebreather mask during that time period. Have you had any experience of pneumo like Dr. Vivek was just mentioning? Any cases like that?
Yeah, not necessarily in the emergency department, but of course we've seen growing accounts of pneumomediastinums among our patients. And it's not because we're not providing lung protective ventilation. I think that one thing that we have to consider, regardless if they're a PEEP responder or non-PEEP responder based on the etiology of what we're dealing with, we have to consider, is the patient have a high inspiratory load? Okay, are they spontaneously breathing? Because a lot of these pneumomediastinums are likely a result of very high inspiratory transpulmonary pressures that are occurring as patients' work of breathing is high during these acute phases, or even in a fibroproliferative phase in late stage or recovering COVID. We're seeing this, and it's because as we're lighting sedation, their workload's high.
Okay, fine. I would like to also bring in Akash at this point to share his experience in Dreihager, which has been a COVID critical care center. What have been your experiences in the ER, and how do you kind of scale up respiratory care management from the ER to the ICU for the COVID-19?
So, as in the ER, in the ER, we mostly receive the patients with the recipient hypoxemia, and we start with the NRBM, and we eventually don't start a HFNC there because we have a limited facility and the limited machine stock. So first we try to manage the patient on NRBM there, okay, and then when the patient stabilizes, we try to shift the patient to the intensive care unit, and then we take the further actions there in the intensive care unit. There we start where we first assess the patients. We see the patient's hemodynamic stability. We assess for respiratory distress, and accordingly take a call for which devices will be appropriate to use for the patient, whether high flow or whether NIV. And of course, prior to that, we would also do a blood gas to see the patient's level of hypoxemia and hypocapnia, if there is any. And accordingly, we will choose the device. Moreover, if we are keeping the patient off on a non-breathing mask, we would like to choose or prefer choosing high flow nasal oxygen with the starting of with the starting of with the starting with moderate flow of 50 liters of the flow, and with the initial FiO2 of 100%, and then gradually titrating the FiO2 levels to achieve our oxygenation. And then we would take the call in case of the patient tolerates well. If the patients are on mouth breather, the patient breathes well and tolerates well through the nasal cannula. Also, we prone the patients on a high flow nasal cannula. We counsel them, encourage them so that it helps them to improve their oxygenation levels.
Okay, that's great. So we be around the globe prone with HFNC seems to be a kind of an answer for us for some bit of the days, right? So I would now want to bring in Vasanta Madam, who, since our topic is multidisciplinary respiratory care, and there's a huge onus on the nursing care that has to be catering to multiple roles. And I'm sure there's no RT in most of the facilities, and the nursing and the PT department kind of caters to all the needs. Vasanta Madam, could you just enlighten us what is the current practice at your facility, and how this is being managed or kind of fulfilled by the nursing and the PT from the ER onwards to in your hospital?
Yes, thank you. Yes, you are right. When there is an absence of RTs, nurses and physiotherapists only taking care of the patients. That is nurses' role. If you feel they have been designated as oxygen nurses. Oxygen nurses, they will be ensuring the assessment onwards, the prescription. They will be with that particular two things. They have to ensure the assessment. Assessment part, they have to ensure about the saturation and then the patient's respiratory rate and then use of other accessory muscles and then the flaring. These are all the things first they have to assess it. Their respiratory, blood pressure, the assessment part, as well as the combination of the assessment part and the prescription of the doctors for oxygen. They have to confirm with this with a proper PPE, appropriate PPE. They have to ensure which type of oxygen has been advised. Either it is according to the saturation, the prescription can be a liters, and then which kind of device. They have to ensure it. And then after ensuring, they have to ensure that they are fitting the instruments, the method of maybe the canalization or mask or a HFNC. They have to use it in an appropriate technique and then ensure it is gaining the saturation within 15 minutes. Every 15 minutes in the initial period of 1 to 2 hours, if they are in ER, they have to check every 15 hours if there is a rise in saturation. If at all, every 15 minutes, if they are not getting any benefit, the saturation level according to the condition of COVID, either it is mild or moderate, and then the severe means immediately they will taken to the critical care areas. So according to the condition of the COVID, the degree of the COVID or lung infection, they have to understand what is the higher level of respiration. That is, what is our goal in aiming the saturation. Either it will be less than 95 or it's going to be more than that. So this ensurement every 15 minutes, if they are checking about the saturation and then the respiratory rate and then properly that is recording and documenting and then giving the report to the treating physician and then going with a further other managements. So with that, if it is HFNC, they have to check for humidification and then their assessment, whether the device is available or which is the bed availability, where to shift the patient without any crisis. So they have to check these things. Meanwhile, their nurse's role will be very much important, the multi-system coordination. Then which are all the physiotherapists to come if it is needed of lung toileting if it is ICU, or otherwise the simple physiotherapy, which is the way they have to coordinate with physician, physiotherapist, and the other members of shifting, especially with the family members also, which type of oxygenation has been initiated, and then how the progress is going, and then remaining concern and other things which the physician has been explained to the family members, and then they have to ensure it for the further improvement or further recordings or further informations if we are giving to the patients. So these are all, and at the same time, the critical care patients, they can go for the critical situations also. So the non-invasive ventilation or invasive technique, endotracheal tube, the setting of the materials which is necessary may be further needed. Maybe they have to get ready, check for the functioning of the instrument, and then align all the materials which may be required further in the process. So these things with periodically every shift or every 2 hours, because of COVID, every 2 hours, our nurses has been done this actually. So they have to check periodically all the things, and then they have to get it arranged and then inform or the particular critical care nurse also. So once a patient has come with the HFNC, and then now the saturation is like this, maybe require the critical care bed. So with the hospital administration, so it's like they have to do the multiple role to care the patient from ER to till to the ward, means oxygen to be ready, the connectors and then the humidification to be ready. If it is ICU, which type of NIV or AET, which to be everything, they have to make it sort of ready along with the family information also. So this is what the nurse's role with a multidisciplinary team approach, and then they have to care the patient with informing, either if the patient is conscious, informing the information to the patient as well as to the family members. I feel this is what they are, from the assessment, they have to keep updating the information to all the team members and then do their preparation also. That is, I feel, the nurses has to be.
Yes, ma'am. I agree with you. There's a lot of multiple tasks that has been
Yes.
on jack of all trades, I would say, that has been happening with this pandemic with our nursing community, right? Dr. Lokesh, you want to add on any any more comments on this particular area or thread of thought?
See, as Madam said already, in our emergency room, after this pandemic, actually, our emergency is always flooded with the patient than the capacity of emergency. So what we used to do is, definitely we all are in our PPE only, all our nursing officers and all our supporting staff, including and doctors also. So we all are in our PPE only. What we do is we do our initial assessment and initial stabilization of patient, and we will see if the bed is there in the, as per the requirement of the patient, in the either in the SDU or ICU. We will just shift him there, because emergency is always, very busy place in our hospital. So this is what we all do. Okay, so let me take the lead now, and Vivek sir, I'll ask you my question. When we shift the patient from emergency to either HDU or ICU, so many times it is being asked to, as from our residents also, that, sir, what should be the ideal time of stopping HFNC to shifting to an IV, or stopping an IV and shifting to mechanical ventilation by ventilator? And one more thing I want to add here, I want to ask actually, sir, one more scenario I hope, I'm sure you have also faced this thing, that even after intubation of the patient with maximum ventilatory support and prone ventilation, sometimes the patient became refractory to our treatment, and they remain hypoxic. So what is your advice regarding either ventilatory mode settings, or maybe use of anything else, any inhaled medication to improve hypoxemia in these patients. So my question is in two parts regarding that.
So I'll take it in two parts. I
Yes.
think in the first part, there is only one thing in COVID. Don't look at anything. Look at the respiratory rate. As Daniel said, it's just the work of breathing. Even if the SpO2 is 80%, the patient is happy and he looks comfortable and the work of breathing. So if the patient is not in distress, if the patient is able to answer your questions, he's not sweating, he's not using accessory muscles, there is no paradoxical breathing, there is no indrawing of the intercostal muscles, and he's comfortable, except the hypoxemia, unless it's by God low. So if the patient is comfortable, do not escalate from whatever. So if you are on, say, NRBM, and if you are moving from 6, you can move to 8 liters, 10 liters, 15 liters, if you are targeting the SpO2. But a decision to move to a level of ventilatory support. So if the patient is comfortable, so it's very simple, speak a few lines to him, ask him a few questions, see whether, so one is he's comfortable at rest. Second is he should be comfortable in communicating with the treating team when they come for rounds. Third is that he should be comfortable with at least the passive movements which our physiotherapy team offers. So if he is then comfortable with all these three things, leave him as it is. If you want the SpO2 to look better, you can go up on the number of liters of oxygen per minute. But if he is having a respiratory distress, and then, you can just interpret it if it's an inspiratory distress or an expiratory distress, and see what is his, do a gas, see whether it is a hypoxemia or it is a rising CO2. If he is in distress, well, definitely you move to the next level of support. From NRBM, you can go to HFNC if it is available and allowed, because many of these patients are profoundly anxious and most of them become claustrophobic the moment you apply an NIV. Give a trial of HFNC. If HFNC is not working, give them a trial of NIV, and give them a trial of NIV. And if you can also do awake prone on NIV. So if the work of breathing is not increased, that means the patient's respiratory rate is not very high and he is comfortable. He can breathe in and breathe out comfortably, speak a few sentences, do a few gestures, tolerate some sessions of physiotherapy, leave him. Otherwise, you escalate and you intubate. So more than SpO2, more than CO2, it is the work of breathing. Otherwise, they become prone to self-induced lung injury. And despite the SpO2 looking good, so if a patient has got a SpO2 of 95 and if he's on a FiO2 of 80%, but he's breathing at around 40, there is no point. And rather, he's worse than a patient whose SpO2 is 86, but who's breathing comfortably at 20 and who looks that he's up and about himself. So I think that's a clinical assessment, and the one thing is work of breathing. Now, in answer to your second question, intubate them, prone them early. Now, after proning, if you have any further requirements, the only way you can meet them is basically, one is that you individualize the ventilatory strategies. So that means try to get an idea of the lung. So if once we have intubated, sedated, paralyzed, try to get an idea of the lung mechanics. There are many patients whom after intubation, we find that even with x-rays which look white, too much white, but once you intubate, sedate and paralyze, you will find that the lung compliance is not so bad and they are getting ventilated very easily. So probably all they have is some fluid, and they don't have a fixed problem. They have some fluid, and drying them up, that is giving them diuretics or keeping them in a negative balance, will help them out. These are the patients who you can just go up gently on the PEEP, and mostly they will respond to a increase in PEEP. A couple of patients, we have done recruitment maneuvers, but before that we have done our prayers, and especially early in the disease, but they've tolerated them well. But so I will say is, first intubate, sedate, paralyze. Please do the inspiratory hold. Please do the inspiratory hold. Get an idea of the static lung compliance, see the pressure volume loop, so you will know how bad the lungs are. Now, if the lungs are compliant, you will get benefit by increasing the PEEP and drying up by using diuretics. Now, if the lungs are non-compliant, then there is no point in increasing the PEEP. And too much of diuresis also is not going to help. It can be counterproductive. Now, once we check the lung mechanics, the second strategy is go in for early proning. But your question was which mode? Well, I always, now that we bought a lot of ventilators in the pandemic in a short time, so every day the doctor will come. So this does not have PRVC, this does not have this. So I tell them only one thing: ventilator is like a microwave oven. When they came in early, when the microwaves, when we used to buy them from Dubai and bring them, they had options like fried rice, grilled fish, cooked chicken, and mutton. But then if you read the manuals, it said low heating for a longer time, high heating for a shorter time. So, you need to understand, and I just tell them, get the lung physiology and match the mode to the physiology. So in this case, and especially seeing the pneumothoraxes, I always prefer to sedate, paralyze, and start with a volume control mode. We tried that we match the 6 ml per kg of an ideal body weight, even if the lungs are not stiff. Because it has been shown that even if the lungs are not stiff and you are using lung protective ventilation, it is better. It reduces the chances of ventilator-induced lung injury. Now, with this strategy, there will definitely be some gain in oxygenation, but you may end up retaining some carbon dioxide. If you are retaining carbon dioxide, accept it till the time the pH is less than 7.2. So till that time, as long as the gases are getting compensated, the kidney function is good, and you can continue with this strategy. So I would definitely like to start with a volume control mode. And most of these patients are long haulers. None of them gets extubated in the first week itself. So all of them so it's a volume control mode, lung protective ventilation, 6 ml per kg of ideal body weight, PEEP, which is titrated to the lung mechanics. Soft and compliant lungs, you can go up to 8 centimeters. I don't advocate any PEEP beyond that. And if there are stiff lungs, and if you have high ventilating pressures and you are not even able to get the accepted tidal volumes, keep the PEEP at around 6. Because most of these patients, when we reduce the PEEP also, or when we increase the PEEP, there's no gain in oxygenation. When we reduce it, there's hardly any drop in oxygenation. So these are not PEEP responders. So there's no point just increasing PEEP. You can keep a PEEP of about 5 centimeters of water and leave it like that. So this is how I set the tidal volume, and then I set the PEEP. We set the respiratory rate to carbon dioxide clearance so that we try to get a PaCO2 of around 40. And we also see that if whatever respiratory rate we keep and the patient is adequately sedated and paralyzed, they don't auto PEEP. So you have to be very careful, because many a times to wash out carbon dioxide, you go in on respiratory rates of 35 and above, but the patient should not auto PEEP. So you can do a expiratory hold, which is good because it gives good practice and then ensure. So that is how I said FiO2. Well, yes, we go on to FiO2 at least to keep the PaO2 of around at least 60, 62 minimum. So at least whatever minimum FiO2, but typically when we intubate these patients, most of them need a FiO2 of 80 or 90%. They need a PEEP of between 6 to 8. They need tidal volumes around 350 and respiratory rate of around 30. Now, this is a good starting point. Then individualize the ventilatory strategies as per lung mechanics. Prone them very early, and once you are proning, definitely there will be a gain in oxygenation, and most of the times there's a reduction in carbon dioxide. So you can come down on the tidal volumes a little, but if you are on PEEP of 8, you can definitely bring it to a PEEP of 6 and dry them up a little. So it is individualized mechanical ventilation. No mode is superior to other mode. It is your understanding of the ventilator and applying whatever best you have at all stages. So from after day 2 or 3, we sort of give them sedation breaks. And instead of continuous sedation, we give them bolus sedations, or we give them a spontaneous awakening trial, but then we take them on to sedation again. Paralytics, definitely we transit from continuous infusion to boluses. And then we see, but typically in the first week, other than giving an awakening trial, and these patients, before they get up, they again get tachypnic. So immediately we blunt in the respiratory drive, sedate them again, give them a paralytic bolus and keep them like that. So individualize your strategies to the lung. Now, many patients who get intubated at the end of second week or beginning of third week, when their lungs are fibrosed, they just don't get ventilated. It's very difficult. You dial in 350 ml, and then, you know, with that, you will be getting high peak pressures of around 40, 45, even when the extra pulmonary compliance is not there. And God forbid, if you have an obese person and you are dialing in even 500, the pressures will go around 55, 60. And in India, typically, we don't have ways to, either calculate the extra pulmonary compliance. So here, what we do is, the standard teaching is sedate, paralyze. Don't look at the plateau pressures. You look at the driving pressures, and if you feel that the extra pulmonary compliance is very high, please do your prayers that there is no pneumothorax. Set the peak pressure alarm at around 50 or 55. Just see that he gets his 6 ml per kg. If he cannot get it, come down on the PEEP first. So here in this place, what we do is, we know PEEP is not going to help in the 3rd week unless there is a super infection or some cardiogenic pulmonary edema. So we reduce the PEEP to 6, 5, 4, or even 3, so that we can generate, given some tidal volumes, and then we leave them like that. So volume control is good. PEEP should be minimum. FiO2, try to come down to less than 60%. God knows when we will achieve it. Keep them sedated, paralyzed for 72 hours. After that, give them spontaneous awakening trials and go on intermittent paralytics. We wait for the day to give them some spontaneous breathing trials in the form of uniform volume control. Typically, they can go to volume assist control, or if from assist control, maybe by day 14 or 15, they may go on to some pressure support trials. But this is how we start ventilating. I mean, if there's anything else you can ask, feel free to ask.
Great, sir. It is very enlightening and informative, definitely, to get the knowledge of your approach.
Yeah, and the other thing I want to ask is that if there is a pneumo, and these patients have crazy, they have pneumomediastinums, then there's a huge debate if you are on a control mode and sedated, whether a ICD will help when there is a pneumomediastinum. The pulmonology never agrees. The ICU is always ready, but and so pneumomediastinum, we are still not sure what to do, but we definitely bring down the PEEP to 1 or 2 and tidal volumes to the lowest possible. But definitely we go in with early ICDs. There are patients who have had bilateral ICDs. So whenever there's a suspicion of pneumothorax, it's not easy to diagnose. We do lung ultrasounds. If we are very clear there's a pneumothorax, and if there is a problem with ventilation and the carbon dioxide levels are going up or the oxygenation is going down, then definitely we put in our ICDs. Most of the time we land up with bilateral ICDs. We don't have extracorporeal CO2 removal with us. We do have facilities for ECMO, but then ECMO is the machines are limited, and the teams are also limited, and jumbo centers, we can't do it. And with COVID positive patients, there are not many takers. And the last thing is, we're carrying out a trial of inhaled nitric oxide, but that is in asymptomatic and mildly symptomatic patient, to get a ventilator which is compatible with nitric oxide, and to do it in a patient who's intubated and prone. We've not tried that actually. The evidence also says it's to be used early, and definitely even in early users, we are finding many patients who get hypotensive with that. Yeah, I've taken a lot of time. Thanks
very much. It's okay, sir. So now I move to Mr. Daniel. Mr. Daniel, if I can ask you, in your part of globe, do you have any different approach to these two scenarios? Like one is when to switch from HFNC to an IV to intubation, and what you guys used to do with refractory hypoxemia even after intubation and prone ventilation.
As Dr. Vivek had mentioned, it sounds like he and I work at the same hospital. He was very thorough, and his approach is exactly our approach. One thing that I want to emphasize is the importance of clinical practice guidelines to standardize care. We know that based on best evidence that's emerged over the last decade and or two, translating best evidence to the bedside hasn't been so good, even though it can improve patient survival. So one thing that I've done at University of Virginia is developed clinical practice guidelines for providing lung protective ventilation at the onset of mechanical ventilation for patients with or without ARDS. So we're already starting out with 6 mils per kilogram at the onset of mechanical ventilation. We're also measuring airway driving pressures immediately after we intubate the patient so that we can get a baseline. And then if we have to go up on PEEP to see if we have recruitable lung tissue, you go back and measure that airway driving pressure again. And if it goes down, that indicates fairly confidently that you have recruitable lung tissue. If that airway driving pressure goes up, it indicates that you may be overdistended. So at that point, the thing that we would do a bit differently is go ahead and individualize that mechanical breath profile with transpulmonary pressure manometry guided ventilation, so that even though we're using low tidal volumes, we want to actually set optimal PEEP, and we have the ability to do that with a specialized ventilator or with a split screen monitor. Either way it works. And also, we heard inhaled nitric oxide. We do use that because of the in selective patients, because of the pulmonary vascular resistance being so high with patients who are demonstrating this refractory hypoxemia. So we want to unload the right ventricle. And then we are an ECMO center, and I know that in many countries, they're not as available. So I think that everything else was very well covered as I was taking notes. With regard to mode, I have always told people when I teach my physicians and my respiratory therapy staff, it's not really mode, but strategy. Some people feel more comfortable with a pressure mode versus a volume mode. So it's really based on strategy. What's your goal? And then by knowing your ventilator, you will be able to apply a strategy that meets that patient's needs.
Okay, great to hear, sir. Now, if I move to Akash, what is your experience as a RT in again the same thing when you guys do this shifting thing, and what you guys suggest, or if you have an experience regarding these patients of refractory hypoxemia? Akash? Akash, can you hear me? I think Akash cannot.
Yes, sir. Sure. So, okay. Yeah.
Yeah, please.
Yes, sir. Is it audible?
Yeah, you're.
Yeah. So, as I said, that when we first initiate the high flow, and we see that the patient is in highly respiratory distress, and then we take the call to put the patient on non-invasive ventilation, where what we do is we try to choose the right interface. So the interface what we choose there is the helmet interface. Okay, we try to avoid NIV mask in the COVID ICU. Because what we have seen is mostly because of the long-term NIV mask fixation, the patients are too much uncomfortable. They're getting pressure shows, and there's a lot of leakage issues from the NIV mask. And what we have observed is when we put a helmet interface, we have seen a minimal leakage. And if there's a minimal leakage, then we could see that there's adequate levels of volume delivery, and we see that the patient improves well. And we do prone the patients on helmet interface. After putting the helmet interface, we do prone them. Now it comes to switching to the invasive ventilation, when we see that the patient is extremely still in the respiratory distress. Okay, and the patient's work of breathing is increased, and this is the time we choose with the patient and ventilation.
There is some issue.
And what we start with. What we electroimpedance tomograph. It has the electroimpedance machine.
Okay, I think.
Hello.
Yeah, Kash, we can hear you now.
Yeah. So once we choose to invasive ventilation, we also attach EIT machine. EIT stands for electroimpedance tomograph, and in that machine we'll be able to see the lungs images. And once we intubate the patient, we'll be also able to see that what part of the lung is getting ventilated. And along with it, we do choose to incorporate Nutrivent catheter, which measures the transpulmonary pressures indirectly. and with which we are able to know that what levels of transpulmonary pressures we are achieving. Along with that, we also calculate the FRC, and of course, what rightly said by Dr. Vivek sir, that we do look for the driving pressures. Of course, we will not look for the plateau pressures only. So first, we try to recruit the patients through the transpulmonary pressure guided monitoring. And we see that if the patients are recruitable, we do not prune them. But after the efforts, we see that if the patients are not recruitable to the transpulmonary pressure guided monitoring, and we see that the patient's functional residual capacity is still low, and the PEEP levels are still at the adequate levels of 8 to 10, then we take a call to prune the patients. We do have observed that once we attach the EIT valve, since we are able to see the lung distribution, the air distributions in the lung, so we are able to know that what part of the lung is not getting ventilated, and we try to position the patients. We try to initially position the patient, say to left radial, so say good lung up and bad lung down. So in that case, what we see is once we attach the valve, we see that what part of the lung is not getting ventilated, and we give the we position the patient accordingly, and we gradually see that the patient's lung, that the part of the lung which was not getting ventilated, eventually started getting some air distribution. We are also able to see the over distensions of the lung areas in that machine, through which it helps us that what levels of the pressures have to be applied, and whether the air is being distributed very well in the lungs. So when it comes to the recruitment strategies, we initially try to recruit the patients on the pressure control mode through the staircase maneuver, and we try to achieve the optimum PEEP. And then we put them back on the volume control mode to what optimum PEEP we achieve, which is around 10 to 12. We keep the same PEEP, and we try to monitor the driving pressures and the plateau pressures in order to see that we are not causing the lung injuries. And in case if we see that the patient will soon land up into pneumothorax, or the patient by mistakenly have landed into pneumothorax, then we reduce the PEEP to the lowest possible of 2 or 3. Okay. Moreover, we have also kept the PEEP of 0 if the patient has already developed pneumothorax, and of course, along with the EIT monitoring, and we report the entire data of at what levels of FiO2, what PEEP were being delivered, and along with that PEEP, what was the functional residual capacity which was measured, and if that functional if that FRC has improved with every incremental PEEP we have done for that patient to recruit. So whenever we recruit, we try to calculate the FRC and see that whether the patient's lung is recruitable. At the end, when we see that the patient's lung is not recruitable, we prone the patient. Then we prone the patients for nearly 16 hours, and then we again supine the patients for the rest 8 hours. And when we see that the patient is improving, and we gradually come down to the FiO2 levels, and we also give them sedation of trials. After, when we see that they are giving sedation vacation trial, we put them on an APRV mode. We have mostly used APRV mode in the intensive care unit, which works for the spontaneously breathing patient as well, and we can partially sedate or paralyze the patient as well on the APRV mode. So we in this APRV mode is also one of the advanced mode, where we set the P high pressures according to the plateau pressures of the volume control mode. And we have also seen that once we switch the mode to APRV, we see that there's a gradual improvement in the oxygenations of the patient, and it may happen that we may not have to prone the patients. So we have seen many times that after looking at the plateau pressures, what we set P high pressures in APRV, and the patient's SpO2 comes up with the increase in the compliance, and by accepting some levels of hypoxemia, we have seen that we have even avoided prone positionings for such patients. But mostly, yes, as we all are doing, when the patient's lungs is extremely non-recruitable, we have to prone the patients and then accordingly do the things. So this was my experience with the very invasive ventilation in the intensive care unit.
Great, Akash. I'm delighted to hear your experience. It's good. Okay, so let me quickly ask Ms. Surabhi, regarding the role of physiotherapy in the high dependency unit and ICUs of COVID-19 patients. So, what is your experience, Surbi?
First of all, good evening, everyone. I am very grateful to the organizing committee for giving me this opportunity. Hope all are doing well. Now come to the question. Mainly in ICU setup, there are the patient with HFNC, NIV, and mechanical ventilator, and they have their separate physiotherapy management. But what's the common management is in these patients, these patients present with severe ventilation perfusion mismatch, which could be overcome by prone position in its recommended hours. Other than this, the airway clearance technique are not recommended during the acute phase of the disease. But in my opinion, the risk-benefit ratio should be evaluated on a single cases basis. For example, if the patient is having pre-existing comorbidities like neuromuscular diseases, COPD, spinal cord injury, etc. So physiotherapy management for the patient with high flow nasal cannula are, along with the bronchial hygiene technique, there are breathing exercises like breathing control exercises, thoracic expansion exercises, pursed lip breathing, segmental breathing, incentive spirometer, and diaphragmatic breathing. With this, joint range of motion exercises, active or active assisted, and bed mobility exercises should be given to these patients. If dry cough is not the issue in these patients, then inspiratory muscle strengthening exercise training can be started early phases of ICU. And if deep breathing stimulate cough or patient is having persistent dry cough, then I would recommend for breathing stacking exercises. That is, take 3 to 4 short breaths without exhalation, and then hold for 3 seconds, then slowly exhale. Through this, patient will be able to generate sufficient amount of tidal volume and can control their respiratory rate. Now, patient with the NIV, positioning, breathing stacking exercise, breathing control, thoracic expansion, assisted segmental breathing exercises are recommended, and most importantly, relaxation exercises that is advisable in these patients because patient is having much distress and anxiety level is too much high. Along with this, limb mobility exercises, like active or active assisted exercises, promote bed mobility exercises also, like bedside sitting, chair sitting, wheelchair sittings. In my experience, if patient is in the ICU or in the distress condition, short-term goal should be more benefit rather than performing the whole exercise session. Even we can alter our goal according to per session and the patient mental status. 1 or 2 exercise should be enough in one session so that patient can easily remember and practice it throughout the day. For intubation patient, the physical management should be frequent change in the position, passive or assisted joint mobility exercises. The neuromuscular electrical therapy or stimulation should be planned in the conscious patient to stimulate or make the muscle healthier. Along with this, technique to facilitate secretions, including assisted or stimulating cough maneuver, chest percussion, vibration, postural drainage, and airway suctioning should be recommended to prevent further complications. This facilitates the functional independence to the patient, and after discharge promote the good amount of quality of life. Thank you.
Okay. Surbi, one more point. Do you feel or experienced any specific physiotherapy maneuver in these refractory hypoxemia patient, intubated patients, and is there something which works more than other?
So, to the best of my knowledge, to date, no such physical modalities are formulated to treat the refractory hypoxemia, but we can do just vibrator technique and neuromuscular electrical stimulation to use in the physical management. Vibration and electrical stimulation stimulate the respiratory muscle function. Other than the modalities, I found The PNF technique, proprioceptive neuromuscular facilitative technique, used up to some extent. This includes the diaphragmatic stimulation like scooping technique, anterior basal lift of the chest wall, and segmental stimulation, which assists to stimulate the normal mechanism of the chest wall and help to regain the ventilation perfusion ratio normal.
Great to hear that, Sabine. Great to hear that. So I'll ask Ms. Tisha to take over from here.
Yeah, that's great to hear from you, Sylvie. I was actually going to ask about rehab in my next, I was going to divert to that area. And rightly, you briefed about rehab to us. So I know that rehab has become like a part of our treatment for COVID-19 patients, and it is an ongoing thing. And it has something that will be emphasized post-discharge also. And even to patients that are at home, quarantine, and that needs to be facilitated to them through at a distance. So it's becoming a prime focus for us now around the globe. I wanted to ask from the intensivist, Dr. Vivek, at what point do you initiate pulmonary rehab for your patients with COVID-19, especially those who are staying with you in the ICU for a long term, and you know how the progression is going to go, and you know that they would need? What time do you initiate? What time do you bring in a team? Do we have a team with us in India, I mean, at your setting, and how does it work? Can you please enlighten us?
Yeah. So we have a strong physiotherapy team. And our physiotherapists have been involved in the management of COVID-19 patients right from the first wave itself. So at our first center, which was a dedicated COVID center, when the physiotherapy team was sent in, they definitely, one part of the team started with the intensive care unit with the conventional physiotherapy, and then they modified themselves to whatever Surbi has said. But the second team went into the wards, and even now we are following the same practice. So let me first cover the wards. So the first answer is, when does pulmonary rehab start? It starts when you are admitted. So there is a team which goes into the ward and which picks out patients with comorbidities or who are at high risk for venous thromboembolism or who are at high risk for atelectasis and who have disorders like sleep disordered breathing, obstructive sleep apnea, or they are smokers or bronchiectasis, damaged lungs due to pulmonary tuberculosis, or other comorbidities which make them prone to DVT. So these are the patients who undergo routine physiotherapy in the ward itself. And here they do both the limb physiotherapy as well as the chest physiotherapy. Most of these patients are mandatorily made to walk. And besides the physiotherapy, they also help out with the positioning and proning. But one of the greatest advantages of physiotherapists beyond their routine active, passive, and chest physio is that I think it gives a huge psychological boost to the patient. I mean, this is unmatched. Doctors taking their rounds and going his away, but when the patient is made to sit and walk, that the amount of satisfaction and the amount of self-confidence they regain is phenomenal. And on the other side, even if the doctor feels the patient is good, but the physios make them walk and they desaturate, they don't have to do a formal 6-minute walk test. But if they desaturate, well, we know, well, this patient needs more support and more aggressive treatment. Now, as far as the intensive care units are concerned, again, so they address patients both on NRBM, on HFNC, on NIV, where they do the routine stuff and just document that whether the patient is able to do out all the activities they were doing yesterday. And in case they are one of the first ones actually to pick up progression of disease. They are the first ones. They'll tell you that today, this patient got tachypneic. Today, this patient desaturated to 86. Yesterday, they were, able to walk a little till with a saturation of 90. But when it comes to the intubated, sedated, paralyzed patients, well, it's full passive limb physio, active physio, chest physio, and of course, they use the muscle stimulator to keep them going, because most of these COVIDs, if they recover, they are all quadriparetic. And most of them have a critical illness, polyneuromyopathy, and it is very, very difficult. So the rehab There's no rehab. It starts at admission. It continues through and through. And we also offer the services of a post-COVID rehab services, which can be virtual when the patient is discharged, and then it becomes physical, and they come into the rehab, and as per in whichever category they are, and they undergo formal again. Basically, they are dealt with by a nutritionist, psychologist, physiotherapist, and they are made to go through the routine activities. Then there's some passive and assessments, physio assessments in great detail, and see whatever best they can do, and then they are pushed to the next step. So I think, but there are many centers in the country where physios are not going in by virtue of whatever practices they have, but our physios have been involved, and we have definitely noted a change in outcomes. And in the ICU, many a times these COVID patients, they either have a left lower lobe collapse, or they have a right upper lobe collapse. And, bronch is not so easy to do. The pulmonologist may not agree. And it is a aerosol generating procedure. Like in the jumbo facility, we have one common negative isolation. All 30 beds are there in that. You don't have separate negative isolation. So our nursing staff is good. And as doctors, we can put the left lung up or the right lung up. But then we tell the physio boss, we need 2 to 3 sessions here. They do whatever magic they have to do, but lungs do open up. Of course, we use ancillary therapies which are not evidence-based, like N-acetylcysteine nebulizations, and we try to use inline nebulizers which are not available all the time. Okay, we don't have vibrating mesh. We've ordered for 1 or 2. It will be coming in. So definitely there is a role. And I think, like we write nutrition prescriptions, which Akash will understand, we also should write the physio prescriptions, and so that they are very focused, and you give them a focused job, they will, in 3 days, your X-ray will look black again. Okay, thank you.
That's great, sir, to hear that, and it's a boost for that faculty of multidisciplinary for us, and I'm sure they're doing a good job for you to talk so much about it. It's really overwhelming. I hope they're hearing it. Dan, I would like to bring you at this point to know what actually happens at that part of the world where the rehab would be a bit more structured than we have it in India. And I just want to know how what actually happens at in your hospital setup, and how it is progressed, and how is the follow-up done, and what is the turnover?
Okay, so we're not as structured as we would like to be, of course. We're at a point where in an acute care facility, we're taking care of the acute patients. We're not very good at rehabilitation. I think that there is opportunity for all of us to improve, not only with ambulation, but with also getting physical therapy more involved towards the recovery phase with basic bedside range of motion. There's also been some discussion through the panel about functional electrical stimulation. And I think this is a growing area that I'm beginning to see appear in the medical literature, where electrodes can be placed on the obliques, and then maybe twice a day for 30 minutes, they're doing functional electrical stimulation with surface electrodes. And 2 pilot studies, one came out of Australia, the other one from Holland, pulled together, I think the sample population was 40, and they indicated that while the diaphragm thickness did not seem to improve in terms of mass, days on mechanical ventilation actually did decrease with functional electrical stimulation. So I think this is an area that we're just beginning to explore within my hospital, and I suspect others may follow suit.
Okay, so yes, maybe. And anything about post discharge follow-ups? I mean, have you heard of any plans that are being made for them? Though even I understand they are with the acute care setting, but do you know what is being followed up for these patients post-COVID?
I'm sorry, I don't, because I don't work in our outpatient clinics. All we do here is for the survivors who do come back. Many of them come back with terribly fibrosed lung, but we don't have a rehabilitation center within my medical center, so it's offsite.
Okay, so yeah, So yeah, we are all resource limited, getting resource limited now, and that's something that we should currently, work on and plan on with the government to work on. So I would want to know from Akash, in your center, I mean, you have immense number of these cases, and how do you contribute to the ICU rehab, because you're more with acute care, and as Dr. Vivek was mentioning, it's more of, he puts it from the patient is admitted from the day one. So in your ICU rehab, what all do you involve in ICU rehab from an RT perspective, and how much can you contribute to these patients who are acutely ill?
Okay, so initially when the COVID started, we initially never had the physiotherapists coming into the intensive care unit. So it were indirectly we who were looking, RTs who were looking at the part of rehabilitation. So when we used to receive the patients in the ICU, and when we have stabilized them for say around 2 days, 3 days, we also used to mobilize them on the chair with the NIV mask or with the helmet interface. Okay, and once the FIO requirement comes down, we used to put them on a NRBM and help them walk and mobilize them with little high flow of the oxygen, enabled to maintain a good saturation while walking. Then and during the same time, your diaphragmatic breathing, then chest physio, all these things we used to do in the early times when the COVID started, when we were not having physiotherapists coming into the intensive care unit. Eventually, when we have the physiotherapists coming into the team lately, in this last 6 months, improvement in the part of rehabilitation. I guess there's a network issue. Now it's audible?
Yes.
Yeah. So in the last 6 months, when we have seen that the physiotherapists coming into the intensive care unit, so we as respiratory therapists used to coordinate with them that what all things we have been doing with the patients, and what all things a specific patient requires, whether it comes to breathing exercises or chest physio. So, for example, if you have a patient who's on a ventilator, on invasive ventilation, and whom we have attached an EIT belt, and we know that this particular part of the lung is collapsed. So we used to coordinate the physiotherapist. We used to tell them that we need to give the chest physiotherapy to this patient at this particular area of the lung, which will help open up the lungs as well, and which we eventually see into that electrical impedance tomograph. Moreover, we have also seen that when the patient's FIO requirement comes down, and when the patient is given off sedation trial, we also mobilize them on an invasive ventilation with endotracheal tube. We help them sit on the chair, okay, and we help them. We make them stand on at the bedside with the tube in. Okay, I know it's risky, but we think that it is also important so that they gain certain confidence, and we do it at the time when the FIO requirements are extremely low, and most of the patients are at the edge of extubation. And post extubation, where the more focus on the pulmonary rehabilitation comes, which includes the incentive spirometer and the acapella and the breathing exercises. Which we as an RTs along with the therapists do, which is going on till, and initially when we receive the patient in the intensive care unit, when he or she is not on a very high support, then also the same thing applies for the patient, where we teach them breathing exercises along with the help of his therapist. We help them mobilize. We help them mobilize at least 4 to 5 times a day to help them get that strength to walk. Because we have seen that a lot of patients doesn't even have strength to even stand up at the bedside, and when we eventually do it for a regular basis, okay, we see that the strength again gaining up, and we do it at a very safer side, that we increase the FIO levels. So suppose if I want to make the patient stand on the chair, then I will put the patient on an RBM and put 15 liters of the flow, and I will see the patient maintains 100% of oxygen at that time. Okay, especially when he is standing up, okay, or walk. Or even if he's mobilized on the chair, and then we eventually put that patient back on the bed. Okay, and then slowly we reduce the FiO2 and then come down to the FiO2 which was said already. So this is how we exactly do the pulmonary rehabilitation part in the intensive care unit.
Okay, that's great to hear, and I'm hearing the one voice of being as a team, multidisciplinary, and at least in some units we are having this teamwork that's really voicing out that's going on really well, and the outcome is the patient is getting better. It's really encouraging, and it's really a boost for our topic today to hear on this. And because of such importance of PR and being pulmonary rehabilitation and being the importance of going to tele-rehabilitation, tomorrow in our session, we have a talk on the same topic, and by one of our artists who are practicing it, in down south. So I think there'll be many years to it on how it's being done from her side. And it's great to know that it's happening multidisciplinary at different points. I would like, and we're running short of time, we have exceeded our time limit. I would want to just touch on one more topic before we end for today, which is a very, very important aspect, and that is infection control and how to prevent hospital-acquired infection and protection of our healthcare workers. So I would just want to bring in Vasanta Madam here, and I just want to want her to enlighten us on how this is done with such massive load that's coming to the unit, to the hospital, and with limitations of negative rooms. We don't have negative rooms anymore. Even the most resourced places are not having any more resources and becoming resource limited. So what are we doing for these, this crisis, and how are we segregating patients to critical care, and in the absence of negative rooms, what are we doing? And are we segregating adult and pediatric populations? Is there a concern there, and what are we doing in our hospital setup? Can you please just throw some light on that?
Yes, you are right. Infection control, which is a very big challenge for these patients. For that, we have to follow first infection control, which comes from the healthcare worker from itself. So first, the foremost infection control practice is wearing the appropriate PPEs, mask, and then other for the healthcare workers, because they are the frontline warriors. The infection control has some breach. That is the reason we have lost in all category the frontline warriors. So that is the first and foremost. And then following the BMWs, how to discard the waste, and then we have been kept very appropriately in the hospital side, and then we have taught all the category of the employees how to use this BMW and then segregation. Another one more question you have asked, it is the initial part of the infection control. Another one more question you have asked about the negative pressure, because negative pressure hospital beds, rooms are very much needed for these COVID patients. To overcome these, we have, that is, renovated our wards with the exhaust fans, which is very much easy to consider as a negative pressure. And then we have been given the very much ventilated wards, if it is HTUs or wards, to these patients to overcome this negative pressure. And then the bed distance. We have created 2 meters between one bed to another bed with the appropriate curtains. So these are all the very minimal things we have done in point of control of infections in the ward. And then we have to see the infection control for the nursing practices or how they are teaching. It starts from hygiene of the patient. In each parameter, we have taken care of the hygiene. Maybe the skin care, the mask, the cannulas, which they are using, the tubings, which have been appropriately, it has been changed within 72 hours maximum, and then taking the swab, if it is an ET, taking the swab and sending into the culture, and then identification, and then fumigation of the, that is infection preventing measures from the rooms. We have taken the swab to identify if it is any organism which is growing, So these are all the next category. What we have been reduce the infection control practices. Apart from that, we have to do the suctioning. The aerosol generated procedures, we have been kept with the, we have made a device which we have been made it like a tent. In that we have started doing the tracheostomy, ET, intubation, suctioning, maximum the closed suctioning method, which is very much helpful to, that is aerosol generating will be reduced, and then which will be controlling the infection of these patients. And then for the sanitization of the particular area with appropriate timing, every 2 hours it has been maintained. And then all the bed, that is a bed sheets, their quints, everything has been with the proper timing, which have been reduced for the infections. So which was high possibilities of giving infection, because the prone position, the patient has been kept. So the prone position, there is a very much chance for the patient to wetting the bed and then other things, which has been continuously monitored for these patients. If it is ICU, 1:1 ratio of the nurse has been maintained for them to putting it in prone and then keep watching. Totally the 1:1 for infection control. The handling of the patient, they have been used with the sterile gloves, because they have been already having their nitrile glycerin gloves. Apart from that, they have been given with the sterile gloves when they will be touching the patient. So, and then one patient to another patient movement, which has been reduced. In reduction of the patient visitors inside the hospital premises. It is also a very much, because many patients, they have come with a infection also. They have been mingling with other patients. So which has been reduced. So if we see the infection control, it is not only in the particular inside unit, which has been taken care in a part of every unit, from the healthcare workers till the end of the patient relatives, we have been taken care, and then it has been educated to every common public as well as to the last person who is segregating the waste. So collecting the swab and then identifying the timely microorganism and then treating the patient. This is what the nurses has been reduce the infection control. In our hospital, we have been treated mucor patients and then very less with other infections. And then which is the outside patients only we have got. Inside hospital, those infections are very limited because of that proper handling of the equipments and then the sterile procedure. Maximum the sterile technique which has been useful for each and every procedure, which is very much helpful to the patient. So that we have been maintained in throughout this pandemic, first and second. So this is what the infection control has been maintained.
Thank you so much, ma'am, for your inputs and your experience and what is being practiced at AIIMS. Dan, would you like to brief quickly on any particular point that we have to be thoughtful on, especially when you have this immense usage of our respiratory equipments and, them shifting from HFNC to NIV and then intubation and then ventilator. So, anything that you want to give us as a guideline or any kind of tips that, our delegates can actually kind of focus on, Dan?
Yes. One thing is that...
Okay, yes.
Over to Danny.
Yeah, just real quickly, we know that many of the mechanical ventilator platforms that are on the market now allow not only invasive but non-invasive ventilation and high flow oxygen administration. So you're taking up a single platform of space in a patient's room rather than bringing lots of equipment into a room. The other thing that we have to be cognizant of course, as we're continuing to see waves of COVID internationally, is what this means for our supply chain in terms of PPE. One thing that we've done, because of limited supply during wave 1, is we have taken the monitors off of the ventilator, and we actually have a cable attached to the central ventilator unit, attached to the monitor, and the monitor's outside of the patient's room so that the clinician doesn't have to keep going in and out of the room to make a ventilator adjustment. I think that's a very important comment I'd like to comment.
Yeah, that's a good point. If you have the facility and the infrastructure for it, it's a great thing that we may be able to adapt in future. Anything that you want to add, Dr. Vivek, on the infection control practices for COVID-19 patients? Or in terms of equipments that are being used, or for respiratory care specifically?
Yeah, so there is definitely an increased incidence of infections, the hospital-acquired infections. There's an increased incidence of respiratory infections like ventilator-associated pneumonias. Even for patients who are not intubated, there is an increased incidence of hospital-acquired pneumonias, probably because they have received one of the immune modulators and steroids and they are immune suppressed. There is also an increase in incidence of central line associated bloodstream infections. And when we started, so we were first happy fighting COVID, and then we were happy giving them immune suppressives. But then thereafter until date, we have been not so happy fighting the MDR bugs. So it is presumed that all COVID patients, as they go through ER, ward, ICU, will get colonized, and subsequently when they get immune modulator like a tocilizumab, will get immune suppressed, and at some stage, they will have a transition from the lung or the gut flora. There will be a pulmonary or a gastrointestinal transmigration of bacteria or fungi, and they will have either a bloodstream infection or a pulmonary infection or any other organ infection, and it could be a disseminated infection. So you need very strict infection control policies. To summarize it, we involved the infection control team. There was a huge role for the infection control nurse. We monitored the hand hygiene and the compliance to hand hygiene, and this was pre-donning. Now, once you are donned, it is very difficult to do so. So there was a third pair of gloves which was used in handling patients. The nurses were instructed to change gloves between the handling of a nasogastric tube versus handling of a endotracheal tube versus positioning the patient. While doing procedures, in addition to donning, the doctors and the assisting staff were made to wear the green gowns, the sterile gowns, and full aseptic precautions were taken while putting in a central line or while intubating a patient. Of course, disconnection of the circuits was not practiced, but once in a while when required, it was done. Closed suctioning was implemented and made mandatory, and the closed suctioning was done in a very, very proper manner. In addition to all this, the cleaning of the unit was done with hypochlorite, and I think we used higher concentrations of hypochlorite to up to almost 5% hypochlorite for cleaning the bed rails and other and ancillary stuff around the patient. And the cleaning frequency was increased from once a day to maybe 3 times or 4 times a day. Then we monitored the antibiograms, and many patients grew bugs in the pulmonary secretions like Acinetobacter, Klebsiella, or Pseudomonas. Some of them were colonizers, some were definitely infectors. Then we also grew Candida auris, and then patients had to be cohorted. So the Candida auris patients were cohorted separately, the other gram negatives were cohorted separately. Then we had to move on to the choice of antimicrobials, and we had to stop using carbapenems and go on to a carbapenem sparing strategy. We had to strengthen our antibiotic policies, stop irrational use of antibiotics in the ward. Every COVID entering the hospital, I think none of them needs antibiotics for mild disease. For moderate disease, if they are going on to steroids, and if there is a suspicion, you can start with a simple thing like a beta-lactam and a beta-lactam inhibitor. But beyond that, antibiotics were only used in the intensive care unit, and that too under the guidance of an ID physician. Now, with all this, the rates did come down significantly, but then we have to be extremely careful. And in the end is, I will say, wash your hands even when you have gloves. So the simple question is, how do I do it? So after donning, use a third pair of gloves while handling the patients, and then discard the glove between handling different side of the patients, because you can't take out the gloves and wash your hands. So that is extremely important. And don't touch what is not required, touch what is required. With every touch, you change the gloves and see that the unit cleaning is done meticulously. We've achieved huge successes with this strategy.
That's a lot of work, and I'm sure with the way you're saying, it's all very systematic now, but it would have been a big task for you in the initial period to get to what you're saying now. I would like to just summarize now on this panel discussion, because we have well exceeded the time limit. As the topic was on multidisciplinary respiratory care, I hope we have touched on important aspects dealing with respiratory care of COVID-19 patients, starting from the ER to respiratory management and going into the pulmonary rehab that they would require, and also the infection control as the background, from the time they're there in the hospital. So any final thoughts from any of the panelists that they want to add in before we wind up? Anyone wants to speak anything?
Yeah, I want to say, I think the most important thing which we have learned more than any form of multidisciplinary therapy or any equipment is the presence of human beings. Because when these patients are admitted, they are isolated from their families, and the anxiety is profound. So if the patient is seen by the treating team, then by a respiratory therapist, then by a physiotherapist, then by a dietitian, I think they drive away a lot of anxiety. And this human presence, human touch, reassurance is huge. Otherwise, with patients with NIV and HFNC, we find a lot of tachypnea and tachycardia, and we do the entire workup and we reach nowhere. And in the end, we just understand that, he's afraid he will die because maybe 2 of his relatives have already died. So I think the human presence, nobody can match it.
Great, sir. I think that's a lesson for all of us to take.
I agree with this thing. And, with this discussion today, at least I have learned more from you guys from across the globe, and I'm sure all of the attendees also learned today regarding the management of COVID-19 in different scenarios, including rehabilitation. So thank you very much to all of you, sir. Thank you very much. So I think we can conclude this session here.
Thank you, everyone. Thank you.
Thank you, sir.
Thank you. Thank you all for this opportunity.
Thank you, everyone. Thank you. Thanks a lot. Panel moderators and all the panel members, thank you.
Ms. Amrita?
Yes. Thank you, sir and madam. With this, we have come to the end of the day 1 program. Let's call it a day. I, Hemlata, on the behalf of AIIMS Rishikesh in association with IARC, thanking you all for the active participation and patience listening. For day 2 program, I request all the dignitaries, speakers and participants to join at the same time tomorrow at 4 p.m. Indian Standard Time. The link is sent in the chat box, so you can click there and register yourself for day 2 program. Thank you all.
Thank you. Thank you all.
Thank you, guys. Thank you.
Thank you.